All right, welcome to Cardiology 2. Cardiology 2. So today we're going to be talking a lot about EKGs, what we're actually looking at, how to actually count these boxes, what they mean, what all that stuff means on those boxes, and why you should never just grab an EKG strip and just be like, oh, it's this. Lots of wrongful identifications occur there because of that. So we're going to try and avoid that at all costs. All right, so what is an EKG? The electrocardiogram. What do you think there, Thornton, since you're up here? All right, so it's the graphic recording of the electrical activity. Has no bearing on what? Mechanical activity. How do I gauge a heart's mechanical output? What do you think there? High? Yes. When I face the room and teach, I look at all of you. Okay. So anybody else? Palpation of the pulse and taking a blood pressure. So pulse being the pulsatile wave generated by the left ventricle with each contraction, and then the blood pressure being the force exerted against the left, the arterial walls by the left ventricle. We're seeing what that pumping power is. You can tell a lot by a pulse. Is it how hard is it hitting? Is it thready? What does that tell me there, Harden? It's very, very weak. Yeah. Ain't perfusing very good. That heart is in trouble. For some reason, he ain't got a whole lot of zip. What if it's bounding there, Gabe? Working harder it's supposed to. You can feel it. So the body is a giant conductor of electricity. A giant conductor of electricity. The heart has its own ability to create electricity. What's that called? Baker. You're good. Automaticity. Very good. So it can generate its own electricity. Through what process is that electricity created that I spent lots of time in videos on last week, Tyler? I'm going to brush my beard while I wait on you. Silky. Maybe some ions shifting through a semi-permeable membrane, generating electrical power. This is why I drink after work. What you got, brother?
Yeah, I got it.
Okay, not a thing. Who wants to save him? Sodium potassium pump.
Yeah.
That thing. Remember the sodium channels leak? Create a voltage gated ion channel that opens eventually. We called it flashover. When the oxygen enters the room, bang, big explosion. The same thing kind of happens in your cell. So the electrodes, they are going to be put on your skin to do what? Detect electrical activity within the heart at any given time. Do not let the electrodes fool you. Again, how do I gauge mechanical output? A pulse check. Touching a patient also tells you about their skin color, temperature, moisture. It's an output thing. If a patient's pale, cool, clammy, that should motivate you to think what? Shock. Registry uses those buzzwords, but we're also trying to train you to a point where something happens to stimulate you. What does that mean? You hear pale, cool, clammy, or feel pale, cool, clammy skin on a patient. It's supposed to stimulate you to have a response. The response is, oh no, they're in shock. Here's the steps of order that I do things. Oh no, they're shallow breathing. I need to bag them. You know, we complicate a lot of this, but a lot of it's set up to jar you into an action, to move you into a place of action. Because is it possible? Possible. You could be on scene and it can be a bit overwhelming sometimes. I'll admit to you, there's been times I've been overwhelmed on scene. Now, by my outward appearance, you would not know it. Stone cold there. But inside, I'm having a mini freak out. Like a duck on water. Very good. And I don't believe any of you can sit here and tell me that's never happened to you. Like, if so, maybe you're way cooler than I am. But internally, I was freaking out. And there's been times where I could see the future for this patient and there was nothing I could do. So dysarrhythmias are what we're going to learn about. What is the term dys? That's a prefix. What's a prefix? Thornton. Okay, comes before a word, gives a word location, direction, intensity, color, helps describe a word and what it's doing. So the prefix dis means bad. How about difficult, painful, abnormal? Any of those can apply. So rhythmia, dysarrhythmia, and arrhythmia are pretty similar terms. Dis meaning difficult, bad, abnormal. A meaning without, meaning it doesn't have a focused rhythm. You're going to see those terms be interchanged a lot in your books, in the concepts I give you. I'll probably use the term back and forth loosely. It just means something that is not a sinus normal rhythm. Something that is not a sinus rhythm. Now, why do dysarrhythmias occur? What is a dysarrhythmia? What do you think, O'Neill? Okay, it's out of whack. It's not normal. There's something causing that. Very common is it is irritable heart muscle. Irritable ischemic heart muscle. What does that mean? Not. Yeah. It ain't got no oxygen. Name. So the heart gets pissed off if it doesn't get oxygen. In about 1 to 2 minutes, it's going to start having irritability and it's going to start having ectopic foci. Now, what does it mean for something to be ectopic? Outside of its normal. So we have a conduction system. We spoke about it last week. The SA node, AV, bundle of His, bundle branches, Purkinje fibers. They're in an insulated environment. The conduction system is in an insulated environment. What does insulated mean there, Stafford? Protected from outside stimuli, because we don't want anything to disrupt the pattern of electrical flow. Doesn't mean it doesn't happen. There is a small window there in your EKG, and we'll talk about it, called the absolute refractory period and the, what's the other one? Relative refractory period. So basically that means I've got squishy here. Now squishy is not hard enough to do it, but say it's a baseball. We're talking about commotio cordis. I could throw this into your chest, and if it hits at the right spot at the right time during your EKG process, during that relative refractory period, it could cause your heart to disrupt the rhythm, and the electrical activity will cause you to go into VFib. You go into cardiac arrest. This is common in baseball, hockey, anything with a blunt force type of movement. The football game. Yeah, the football game this year. That's what happened to him. He got hit in the chest and then he just fell out. Very much a freak accident. Very rare happening. Very rare. Now, the absolute refractory period will be the beginning half of that T wave. That's when repolarization's occurring. The heart's kind of going back to that recharge phase. Absolute means what? Nothing can affect it. No outside stimuli. You can hit him in the chest with a sledgehammer in that exact spot. Nothing's going to happen. But the relative refractory period, that small little window on the butt end of that T wave, if anything hits from the outside right there, cause them to go into commotio cordis or VFib. So dysarrhythmias from ectopic foci are usually a tachy dysarrhythmia. What does it mean to be tachy? To be fast, right? Or to dress horrible, like Renee. That's not nice. I'm recording. Oh, they can't see you. Are you okay? Get it together. So tachy dysarrhythmias means it's a fast arrhythmia. All right. And this ectopic foci, ectopic means it's out of the normal insulated conduction system. It is over there in left field. What does that mean? Well, I'm going to show you. Let me get my little pencil marker here. Bear with me. I am not a super artist. And you can't see what I'm doing. Perfect. I will fix this there. All right, so we have the heart. You agree? How many chambers does the heart have? 4. All right. SA nodes up here in the top of the right atrium. AV nodes over here. Now we got all these guys in the conduction chain. Now what ectopic foci means is that there's a little guy over here. Let me just change his color so he's easier to see. So he's over here all pissed off. Now, what about cardiac cells do we need to remember? They have the ability to have automaticity. Just because they're not in the conduction system does not mean they cannot do what? Generate some electricity and stimulate. So this guy over here or this guy over here is pissed off. He has enhanced automaticity, which means he's got super electricity. This is like going from Pikachu to Raichu. It's evolved. More power. More power. So what it does, it spontaneously depolarizes. What does that mean? So it'll generate a giant electrical wave that will cause the heart to do what? Depolarize and contract early. This is called a PVC, a premature ventricular complex. Gabriel, what does it mean to come prematurely? To an event, any event. It's getting too excited and arriving too early, disappointing everyone.
Even myself.
Even yourself, yes. So these ectopic foci will cause premature events to occur in the myocardium. It will throw the patient's rhythm off. One of the things we look at when we look at EKG is the rhythm. Is it regular? Is it the same space apart every time? Is the big spike the same number of blocks apart every time? Even that, Mr. Walker, is important. Counting how far apart these blocks are. You see what these are? What are these? These are calipers. And I got to tell you, you ain't seen many people walk around with these, are you? I carried them, but then I lost my top to them, so I stabbed myself in the finger one time, so I quit carrying them. But there's ways around that. You don't have to have any of these, but they do help when gauging regularity, when using that small pin there to count the boxes, which we'll talk about the who, the what, the when, the why here in a minute. You have a question? Okay. Yes. Do not just treat the rhythm that you see, because the rhythm could be full of poop. Not that it always is, but sometimes we have things like artifact. Sometimes we have interference. I'll give you an example. 60 megahertz interference. You ever stood next to a power line and heard it humming? You can go stand outside in the parking lot by that big old generator, and like you can hear it humming, the electrical power. That can throw off your monitor. So an EKG analysis should be done in any patient with cardiac condition. But if you come through here, what am I pushing you to do? 12 lead everybody. Why? It rules it out. It also gives you the ability to be thorough. I cannot tell you how many patients I found crap on just by being thorough. They wouldn't even complain of anything cardiac, but because I'm looking, I find things. And also, I can't tell you how year after year, students come in here, we do cardiology, they start 12 leading everybody, aggravating everybody on their crew, by the way. But they start finding things. They come in here, and so will you, except for you training center boys. Where y'all at? They ain't here today. Look at that. So they'll come in here, and you know what you're going to say to me? Hey, I'm glad I 12 lead everybody because I found things. And I'd be like, imagine that. Interesting. So the monitor is used for what? Monitor during transport. Why? It is a baseline vital. It's not, some people don't consider it a baseline vital. I'm telling you, if you are of me, you represent the school of thought that I come from, and I can only hope to influence you, that you will consider an EKG a baseline vital. And I can promise you, when we go back to the arena here soon, and I feel comfortable including this in your arena assessment, you're going to want to do an EKG on every patient. Why do you think that is? When I was teaching you assessments last couple weeks, what did you learn most of all? To be what? Thorough. And when y'all can do EKGs, that's going to be another component of being thorough. Because after you've learned how to read them and do them, guess what? I'm going to throw these things at you. So monitoring during transport. Why do we take baseline vitals in the first place? So I can trend improvement or deterioration. Improvement or deterioration. You print the strip for dysrhythmia interpretation. You print the strip. You print the strip. You print it. You don't just look at the green squigglies on there. Why? I cannot interpret it. On that software that is included with these monitors, there will be interpretation software. They be lying. Sometimes the interpretation software is pretty close. I would use it as a guideline to confirm my interpretation of the rhythm. But I can promise you there are medics running around out there like, well, this thing says he's having a STEMI. But sir, I called for a broken foot. I'm 12. You're having a STEMI. Shut up. This thing will be lying to you. Again, it's a machine. You cannot trust it. So standard leads. We have lead 1, 2, 3. 1, 2, 3. So simple put, it forms what we call Einthoven's triangle. A quick look at the heart gives you the 3 leads. Just putting pads on a patient gives you 3 leads, 1, 2, and 3. This is good for what? Rate, the rhythm, and quality. The speed matters. The speed matters. When we talk about inclusion and exclusion criteria, memorizing the criteria for a rhythm to be what it's going to be, some rhythms can be excluded by just their speed alone. What does that mean? The heart rate's 150. Is this sinus brady? No, it is not. So I can exclude that from all my choices to pick from. Is it a idioventricular agonal rhythm? No, it's far too fast. So the criteria helps me include and exclude. You want an example? Very good. A rhythm that is irregular R-to-R interval, no discernible P waves, chaotic baseline is going to be a AFib every time. Why? Well, it's fibbing. It's not regular. Ladies, you ever had a man not be regular? He's fibbing. I'm telling you. Why? The R-to-R doesn't line up. One of these things is not like the other. So it's irregular, therefore it fibs. Make sense? Yeah. So every time that's going to be a fib. It has those 3 big criteria to identify it. It has 3 big criteria to identify it. Another example, SVT, rates over 150, narrow complex QRS, no discernible P waves. It's so narrow and skinny and fast that it can only be SVT. There's 3 criteria right there. No P waves, over 150, skinny, narrow, complex. Every time that will be SVT. The reason I'm giving you these examples is that it will never not be SVT because it will line up with the criteria. Can it be something else? Can it be a sinus brady, a junctional brady, an AV block? No, all these are excluded by you taking the time to measure, read, calibrate each one of those little boxes. I should never give 3 of you one EKG strip and get 3 different answers. But I can promise you, you've probably been on scene and had a couple medics there, and you give them an EKG strip and you get 3 different answers. Tell me I'm wrong. Why? They're not being systematic. What's the key to this? It's to be systematic. I'm going to teach you a 5-step process for EKG identification. I'm also going to give you access to an online game you can play called SkillStat. You've been playing it? Pretty fun, ain't it? And it helps a lot. SkillStat's very fun. It's also free. I like free because, you know, you got no money. Look where you're at. So 12 lead provides detailed information about the heart's conduction system, records activity from 12 separate angles, a full 360 snapshot. It's an electrical snapshot, not a mechanical. How do I get mechanical? I do well. How do I get a mechanical output? Yes, take a pulse. How many times have you seen providers scared to put their hands on patients? Now, I get it. No glove, no love. I get it. Everybody got Ebola. until proven otherwise. I'm with that. But putting your hands on a patient can actually let you learn a lot about them. Let's say you're at a nursing home, you touch a patient, they're burning up to the touch. That automatically should turn your diagnosis meter to where? A septic patient. There's a reason you need to put your hands on these patients. 12 lead devices do contain interpretation software. Use it as only a one party of assessment. What do I mean by that? What do you think, Not? Okay, I like it. I like where you're at. Who can add to that? There it is. It's a tool. It's like a mouse tool. This is a surprise thing we're going to use later. Look, y'all got kids? None of y'all? Anyway. So, it is a one party of assessment. Use it to confirm your diagnosis. Don't use it to do what? Be the diagnosis. What if you don't know the rhythm? What if you just, it's a big mess of jumbled crap? Call it in. Don't guess. Because I'm going to promise you this. Look at me. I have been doing this a long time. I've been teaching cardiology a long time. I have looked at these things before and be like, I don't even know. I can't even guess. Because it's something mixed with something else. I can see where it could be this, but we have in EKGs and in electrophysiology fusion. Fusion is when Goku and Vegeta do what? They merge together. So some of these rhythms have fusion, actual fusion, and partial fusion. And when there's a lot of fusion going on, it can get wonky. That means it can be hard to interpret. That means that we need to do what? Transmit. Don't sit there and guess. And it's a pride thing. It's a pride thing. Can you tell me there's not medics out there that like, you can see on their face they didn't know, but they had to give you an answer because they're the medic, right? Eat some humble pie. Just be like, you know what? I can't tell. It's got a lot going on. Let's transmit it and get an answer. That's hard to do for some reason. Why is that, Thornton? Why can't we let go of our ego? Everybody expects you to have all the answers. And that's okay not to have all the answers. That's going to happen to you. You know that, right? As soon as you get your paramedic license, they're going to expect you to just have all the answers. Biggie, the day his license dried, he had just tested, got his paramedic license, hadn't even got his state numbers yet. They were trying to send him on an ALS call by himself with some OB woman bleeding to death and having a baby. He called me and I'm like, sink or swim? You out of class now, boy? The only thing you can really do is a funnel massage. Just try and stop that bleeding, transport rapidly. I mean, whenever Grady gets there. Expeditely, quickly. And they do an amazing job carrying all their equipment in. Correct. But if you don't know, don't guess. Transmit. It's okay to tap out. Like, hey, I don't know. I'm just going to keep them alive until we do know. If you can't make it better, don't make it worse. So, the electrocardiogram amplifies impulses and they record it on graph paper. Why on graphical paper? So I can count the boxes. So it has a standardized format for me to gauge against. So there is a thing called artifact. Artifact is false rhythm generation. Muscle tremors can cause artifact. And if it does it long enough, what will the monitor do? Start alarming. Patients in V field, if it talked. It'll start alarming, saying the patient's in V field. Shivering. A patient that won't stop moving. All right, sir, I need you to stop moving for a second. Hold your breath. What we're going to do is what? Take a quick picture of your heart. And then you still have those patients just like, I don't want to. I can't get a good reading. What's even worse is that you wait till you're doing what? Down the road, bumping and grinding. That's not going to be a clear picture. It'll give you some picture, but it's my advice, and you can take it or not, my friend. The first few minutes of me interpreting a rhythm should be on scene with a patient before I've even moved them. Why do you think that's important, O'Neill? Absolutely can. Actually, very good. So here's what I want you to do. Get in the habit of either you or you and your trained EMT who you've already had this conversation with. As we take baseline vitals, if you come from the school of thought that I'm giving you, baseline vitals includes an EKG. Within the first 3 to 5 minutes of meeting a patient, you should have all their vital signs and an EKG. A clean, non-moving, bouncing down the road EKG. Now, a lot of you are first responders, as in you respond first, you are paramedics, but you don't transport yet. I done seen them out there, them little ambulances y'all got. Can't wait to see you run around in them all like clown car. But those clean EKGs are necessary because what drives my treatment? What do you think there, Gabe? Well, outcome is what my desire is a positive symptoms, signs. My assessment drives my treatment modalities. Could me interpreting a rhythm wrong change my assessment, then change my treatment? Could me even taking a blood pressure wrong? That's the difference in CPAP getting applied or not, right? He can't breathe. He's got a CHF exacerbation, right, Baker? He's got a CHF exacerbation, and his blood pressure is 80/40, but it's not actually 80/40. Small details matter. What if it's a person with tiny little squiggly arms, no muscle mass at all, like Stafford over here, and you put a big old normal adult cuff on him? It's going to be a false reading. It's going to give you a false low reading, right? So it's not accurate. Those small decisions play a role. Those small decisions play a role. So if his blood pressure is coming off at 80/40, could he get CPAP? No. So does it matter? Those details matter. Next, we talked about a loose electrodes. What does it mean to be loose? Hi, you're the expert. Tell me about it.
It's like the electrodes, when the patient's sweating or something like this, it's not sticking.
Okay. How do we make an electrode stick if they're sweaty? Wipe them off, then tape them down. You know how to make anchor points? I'll show you sometime this week. Sticky right here, but it's not sticking because he's sweaty. Get some tape, make anchor points. I don't care how terrible it looks. As long as it can pick up the EKG, that's all I care about. It ain't got to be pretty. And when we get to trauma, I'll tell you this. I'm not one that's big on making my bandaging or my splinting very pretty, because you know what they're going to do when I get in the ER? They're going to cut it right off. So if you're more professional than me and you think it has to be pretty, you do you. But I don't care if it's ugly as long as it works. We done talked about 60 hertz interference and then machine malfunction. Is it possible your machine could malfunction due to lack of care, mishandling, abuse, lack of calibration by monitor spec technicians that are supposed to come about 6 months to every year? The answer is yes. It very well could goof up. So what else can I learn from an EKG? Let's talk about it. It can give me heart rate, regularity, the impulse conduction time intervals, how long it's taking an impulse to travel from the SA to the AV node, or how long it's taking that impulse to travel from the atria to the ventricles. That's what it represents. Can it also show me abnormal conduction pathways? Absolutely. I'll show you later on this week when you can tell when electrical impulse has traveled, hit an area of obstruction, and then had to find another route around. It's called aberrancy. Can it tell me pumping action? No. Cardiac output? Cardiac output is what? Heart rate times stroke volume. So the amount of pumps per minute. What is stroke volume? The amount of blood ejected from the ventricle with each contraction is stroke volume. Blood pressure is what? Okay. Amount of blood being forced out of the left ventricle, the pressure exerted against the arterial walls, and cardiac muscle hypertrophy. We can, to a degree, tell if somebody has some cardiac hypertrophy, left ventricular hypertrophy to be exact. There was a recruit that came in here a couple of weeks ago, and he said he just wasn't feeling right. So we put him on the 12 lead, and I looked, and I was like, you ever been told you have an enlarged ventricle? He's like, yeah. I was like, do you have high blood pressure? He's like, yes, I do. I was like, Well, the reason you have an enlarged ventricle is because your left ventricle is pumping against a greater force. What is progressive overload? Heavier weights makes a bigger muscle, right? And that's what happened to his left ventricle.
I had a question.
Okay, you have a question?
I had a lady that said she had a mitral valve.
Prolapse. Well, you can ask the question. I'm sorry, I didn't mean to jump ahead, but mitral valve prolapse. What is the mitral valve? We talk about tricuspid pulmonic mitral aortic. It's prevent backflow, right?
Mhm.
So prolapse means what? If you have a prolapsed anus, what's happened? It's hanging out, right? It ain't supposed to be hanging that way. You got a prolapsed uterus. What's happened? This happens at nursing homes. That thing will just fall out. Also, don't try and push it back in. Just put a sheet over it. Transport, go guard. So something prolapse means it's going to fall out of its normal place, right? So a mitral valve prolapse is the same thing. The mitral valve is done got weak and raggedy and then fell out of place. So it's now not working like it's supposed to. Make sense?
No, I understand, but how do they fix that?
Valve replacement. They can do valve, a pig valve, mechanical valve, or cadaverous valve. So a dead body valve, pig valve works very good, and the mechanical valve. And it's not a pleasant thing. He's right. It's going to be open heart surgery. So we have predetermined spots, usually using a adhesive with gel center. These things are stickies. They stick really well sometimes. Why won't they stick?
Like area sleep.
What do you mean hairy? What's that mean? So if somebody is hairy or sweaty, it'll be a hard time to stick. So it may be necessary to give them a shave and a pancake. A shave and a pancake. It may be necessary to shave them. Now, some of us have very mild chest hair. Some of us have fur. Austin, you're hairy like onion. Some of us, what you got, Baker?
Question about
So it's not more of a preference. It's about where the limb lead's going to lie to give me the better picture. That makes sense? So I like to do salt, and no matter what, the white lead's going to be over here. But I use salt, pepper, ketchup, pickle. Some people like smoke over grass, blah, blah, blah. That's firefighter terms. I'm a foodie. So salt, pepper, ketchup, pickle. And some people like to bring those leads out farther, like they'll put them on the legs. You probably met people like that, right? Now, that's all about preference. It's still going to pick up. But me personally, the best I can explain it is a scope. I'm still going to get a bigger picture, right? Like this. But if I narrow the scope and put those on the abdomen, what's it do for me? Narrows the scope. Visualization's the same, but for me, I found it to be more effective and clearer picture for me, just my personal opinion, if I narrow the scope. That makes sense?
There's a certain condition you would want to have a narrow versus a wide scope.
Not to my knowledge. I just want to look and see what's going on, what that rhythm graphical representation is. Is it too fast, too slow, or is it like an FLB, funny little beat? Is it dangerous to the patient? Because what's the rule? If I can't fix it, I don't need to make it worse. And if it's not broke, do I need to fix it? If they got some kind of wonky rhythm, but their blood pressure's good, they're talking to you, do I have to mess with it? You do not. You don't always have to respond. You do not always have to respond.
Do you prefer to put lead on deltoid to the chest? I know a lot of you.
My preference is to go more shoulder. But again, it ain't gonna make a huge difference.
I think they have to.
Yeah, we was talking about the scope. You're good. Now, the thing that does matter is your 12 lead placement, because V1 and V2 are actually looking at the septum of the heart. So it's looking at the middle. V3, V4, that's going to be the anterior, the front. And then V5, V6, AVL, and 1, that's looking at the lateral portion. Where's the lateral? Medial is closer to the midline, and lateral is farther. So lateral is actually that side of the heart. So that placement does matter to get the best and clearest picture possible. What you got?
I put it right here. I've seen people do it this way where they put
What's
it
the big axillary?
two, no, maybe.
So a good gauge for that would be, now this is a loaded question because, you know, some people be droopy. V4 should be at your nipple, like right below. Yeah, V4 should be right there below your nipple. And V3 should be between V2 and V1. And yes, and when we get in lab, I will show you how to put one on the way that I do. And again, as long as it's pretty close, it should be fine. You know, this is all the best we can do as far as our diagnostics in the field. Now, rubbing the site with alcohol swab before applying the electrode. Why is that a good principle to go by? What do you think, Baker?
It had to be more active.
Okay, it'll help with adhesion, but what else? It'll remove what? Dirt, oil, skin flakes. You ever had somebody, let's say you're starting IV, you use that alcohol swab. I'm like, and it keeps getting dirtier. I'm like, I get a new one. Are you a crayon? What's going on? Yeah, so remove that epidermal layer. What? He made something terrible, I'm sure. So rub the site with alcohol. Shave your patients. Does everybody have a razor in this bag? That's good. That is option B. So worst case scenario, what if you ain't got a razor? What if you didn't check your bag off? You can take the multi-purpose pads, put them on and do what? Give them a quick good waxing. Look at that. You called and got a free waxing from the Atlanta Fire Rescue Department. The good hands people. Oh, Kelly Clarkson. So each pair of electrodes is a lead. 12 leads EKGs are now very common in the field. Very common in the field. What does that mean? When I started, and when some of you started, probably just you today. No? 12 leads weren't a thing. 12 leads were not a thing. It's only over the last probably 10, 11 years that all trucks have 12 lead capability and medics are now expected to be able to read one, versus back in the day, it was just put on the 3 lead, and if it's too fast, slow it down, too slow, speed it up, and if it ain't got nothing there, pump the chest kind of thing. Save them. So the bipolar leads. What's it mean about be bipolar? I didn't look at you. You came? Everybody look shocked. You paid for this. Remember that. Paid hard-earned money for this. So what does it mean? It means you got two polar opposites, right? So bipolar means it's got a positive electrode and a negative electrode. What? Yeah, we're talking about the electrode stickies. We're forming what I got a picture coming up. We're forming Einthoven's triangle, and that will cause you to have the formation of the leads 1, 2, and 3. So what does it mean to be bipolar? Bang, let's take a look. So we have up here what? Lead 1 is the one going across the chest. So it's got a negative and a positive. Why is it called bipolar? It's got a negative and a positive lead there. All right, so what about lead 2, which is coming down across on the right side? A negative and a positive. Why are these called the bipolar leads? They have two different leads there. They have two different polarities. Now, bipolar leads only provide about 3 views. 1, 2, 3, making that Einthoven's triangle. So with the 3 lead, what can I actually see? Rate, rhythm, quality. With the 12 lead, I can see greater depth, a 360 view of the heart. I can see ectopic foci in greater view. I can note the presence and the location of infarcts. I can note in great depth if there's any kind of ventricular anomalies going on or if there's any hypertrophy going on. A 12 lead gives me a lot more information, but a quick look is a quick look. You can throw on the 3 or 4 lead there, or you can put on pads. The pads give you leads 1, 2, 3. Put pads on and you got leads 1 through 3. And while we're talking about it, you're going to be tempted again to think about a asystole rhythm, which is what? Cessation of cardiac activity versus fine VFib. You have coarse VFib, which is big, messy, and got a lot of electrical amplitude. But as the heart muscle cells start to die, the VFib starts being big and juicy, right? It starts to be very fine and little VFib. Fine VFib and asystole look very similar sometimes. Why? Epinephrine is trying to get those cells back working, but time to go home. So we have to confirm through 3 leads that the patient is exactly in asystole or that they're in VFib. What if you can't tell the difference? What if it's just too close to call? When in doubt, shock them anyway. Because VFib you shock, asystole you don't. What if you can't figure it out? We better go ahead and shock them, do compressions, do the whole thing, then guess. Why do you think that is? Better safe than sorry. I like that.
Because if they are in you can shock them, you have a chance of getting them into the next little
Workable rhythm.
rhythm. And it only takes a second to shock them.
Does only take a second to shock. He leads. Einthoven's triangle is the basis for placing EKG leads. What does it mean to be a basis? To form a base is what? Starting point, right? Starting point. Y'all hear me with that fan? I just, they won't be able to hear me if they're recording. So yet again, what can the 3 lead tell me? The rate of the heartbeat, that matters. Regularity. How about the time it takes the impulse to travel through various portions of the heart? I'll give an example. When we talk about the PR interval, the P wave representing atrial depolarization, and that impulse traveling from the atria to the ventricles, that is the PR interval. How long it takes from the P wave to get to the QRS complex.
Take it down. What do you need to fucking do?
What I'm here for. The book will complicate it. All the P wave is doing is saying electricity traveling through the atria, causing it to contract. That impulse will then go to the ventricles. The P to R is how long it takes that impulse to travel to the ventricles. The QRS represents the ventricular depolarization, to where the ventricles are stimulated by electricity, they contract and beat. That's all. So, what are we doing over here? Okay. Did I? Okay. So, but the single lead, the 3 lead can only provide what? Rate, rhythm, quality. It cannot provide the presence or the location of an infarct. So, how do I tell the presence of an infarct? ST elevation. I can tell ischemia by inverted T waves, depressed T waves. ST depression, there's another one. Axis deviation, I can tell that. Chamber enlargement, right to left differences in impulse or conduction delays. The quality and presence of pumping action. Now, can I tell if it's got a mechanical pump, or can I just tell that the electrical output is good? Come on, somebody. Just the electrical output. I think we're getting a good idea. Another example of Einthoven. Won't waste time there. So the limb leads. They are augmented voltage leads. Augmented voltage. So your AVL, your AVF. Your AVL, your AVF. These leads are created to using 4 limb electrodes. They combine with the other leads to give you a different viewpoint. What does it mean for something to be augmented? Stafford. Quit manipulating me.
Pretty much all of what they said already. Like something's augmented, it's changed or manipulated to get a result.
Okay, so we're manipulating to see what result. I'll give you an example. The augmented lead AVR is not typically evaluated in the pre-hospital setting. That'll give me a posterior view of the heart. And it takes extra time to view that because a lot of people want to do that right-sided EKG. But the AVL, we view that from the lateral standpoint of the heart. That gives me a lateral viewpoint of the heart. AVF, look, it makes that little T or that cross over there, right? What do you think AVL is evaluating if it's coming down there from the bottom looking up? Inferior. So AVF is at the bottom looking up like this. Looking at the bottom of the heart, the inferior portion of the heart. So far we've got bipolar leads being leads 1, 2, 3. So 1, 2, 3, make an Einthoven's triangle. And then we have the augmented voltage leads that are created using those 4 electrode leads. Go ahead, sir. Nah, we don't use it very much. Your book said that? You've probably heard that. Most medics are going to ignore it. Unless you're doing a right-sided EKG, unless you're trying to confirm a posterior. But if I've got suspicion of an inferior infarct, I'm definitely going to have right coronary involvement. I don't need to confirm it. It's probably there. My treatment won't change at all, so I'll only waste time doing it. And what that patient needs more than anything is what? Cath lab, not me sitting here being cardiologist on scene too much. But if you got the time, you're waiting on Grady, why not? Looks cool. Look at me, I did extra stuff. I'm helping. So the limb leads are what? 1, 2, 3, AVR, AVL, AVF. So the big 2 I want you to remember today are AVL, looking at what portion of the heart? Lateral. AVF, looking at who? Very good. The bottom, inferior portion. I'll give you a second to write your notes. If any of you are writing notes. Make your notes, make them good, write down stuff. It's cool. Doolockies. Wipe your hands, wipe your face. Face. Some of you may die. That's a sacrifice I'm willing to make. All right, everybody got their notes down? Moving. So, limb leads are 1, 2, 3, AVR, AVL, AVF. For continuous monitoring. Because you can't have somebody sitting on a 12 lead all day, right? Most of your monitors won't even have the ability to sit there and let you view 12 leads throughout the entire trip. So you'll have to do what? Use the standard limb leads for continuous monitoring. Me personally, I take an on-scene 12 lead. And then as we go down the road, I'll monitor them with the standard limb leads, 2, 3, 1, AVF, AVL. And then as we are going down the road, I'll take a secondary 12 lead, maybe 10 to 15 minutes within my transport. I will transmit my 12 leads to the receiving hospital. What does it mean to transmit something? Send it. Send it. Why do I want to send the 12 lead to the hospital? Why do I want to call a possible stimulator? What am I doing that for, Gabe? Right, to have a cardiologist be like, confirm or deny that this is a STEMI. And if I do call a STEMI alert and I'm wrong about it, is that okay? Absolutely okay. It's better to call it and be wrong than not call it, and then they actually have a STEMI, and there's no cath lab team sitting there waiting on them. Their door to balloon time for most of these cath labs is supposed to be about 90 minutes. As soon as they get the patient inside, they start prepping, and they should have a balloon in their coronary arteries, inflating, pulling things out, or stenting, or whatever they're going to do. Within 90 minutes, everything should have been done, and the patient should have reperfusion occur. What does reperfusion mean? reestablishing a blood flow, which will give me oxygen. Very good high and high. I want to remind you that EMS, firefighting, and all that, we are the special teams of the medical world. In regards to football, what do special teams do? They sometimes will kick a field goal, or they'll sometimes do a fake and then pass, right? Most of the time, though, they're punching the ball or kicking the ball downfield. Why? Field position. We need field position. There's no patient that will benefit from you staying on scene for anything to do with them having chest pain. They need a cardiologist and a cath lab. Reperfusion means that we can get blood flowing back to that heart meat, and the dead meat won't die. If it's dead meat, it won't beat, but if we can get that blood flow back to it, it will beat again. It will use again. It will be able to conduct, contract, automaticity, excitability. It'll have all its little functions back. And then what happens once the patient leaves the ER? They swing by Bojangles. Finish him. Motaro wins. Dr. Danielle Bellardio is a cardiologist from Texas. And again, I think I've shared this with you, but her studies have shown that patients that just take their medicine after having a big coronary event, they have a 20% chance of it, changing them and it happening again. 80% chance of it happening again. But somebody that's had lifestyle changes, they have a 20% chance of it happening again. It causes a huge reduction in numbers if you actually change your diet, your lifestyle, get more active, blah, blah, blah. We don't want to hear that, do we? Tell my mama last night, she's like, I'm gonna get this juice cleanse. I'm gonna lose this weight. I'm like, Mama, you're looking for a magic button, a magic pill. Take your butt to the gym. Be consistent with what you eat, and that's all it takes. It's a simple equation. Burn more than you take in. But a lot of us in America especially want a magic pill, an easy button. Just give me a pill so I can feel better and not have to go back and do another open heart surgery. What does that sound like? Majority of y'all's patients? Yeah. All right, precordial leads. Let's stop, pause, review. Bipolar leads, O'Neill, are
I'm gonna say, voltage, API, ABS. You wanna know, or you wanna know the right quality?
so bipolar means what? I asked you because you're the expert. They have a negative and a positive attachment point, right? They go between two extremes.
Oh, I didn't know that.
I thought you'd know that.
Okay.
No, it's fine. So the bipolar leads are leads 1, 2, 3. They have two attachment points, negative and positive. Next, we have the augmented lead, which would be AVR, AVF, AVL. Those are your limb leads. Everybody with me so far? Now, the precordial leads view the heart in a horizontal plane. Let's do that again. The limb leads view it from up, down, side, and back. The precordial leads, V1 through V6, are unipolar. What does unipolar mean? They have one polarity. One polarity, and they view the heart in a horizontal plane. So they view it from a calculated point called Wilson's terminal, which is, you can think of it kind of the center point of the heart. And basically what it does is it bisects Einthoven's triangle and gives you a reference point to gauge your interpretations off of. It's building this graphical waveform off of that. How do I make sure it's as accurate as possible? Lead placement, electrode placement. What are my limb leads, Gabe? So V1 through V6 is all precordial leads. So what about my limb leads? You to my lead 1, lead 2, 3, AVL, AVR, AVF. You're fine. I imagine you worked a whole bunch last night in Roswell. Somebody slipped in caviar again.
No,
Jay Christopher. Figures. So let's pause and do that again. My precordial leads are unipolar. What does that mean? Not. Okay, we're close. They have one polarity. Just one polarity.
Kind of positive and negative.
Just one polarity. Just the positive. So my bipolar leads, O'Neill,
Positive and negative.
I got a positive and negative. So they go between two extremes, right? So what bipolar means? Very good. So the precordial electrodes must be placed correctly and consistently. Correctly means the right way. Consistently means what? Every time. Now, there is a time and a place where that would change. Why? Shamu. This planet equator looking summer gun would be challenging. Another person that would be challenging. Meemaw is 85 years old. And them titties be sagging. Do they hang low? All the way to the floor? Can you tie them in a knot? Can you tie them in a bow? So they be sagging. So what you do is you flop that thing over her shoulder, backwards, and get up under that thing. All right, so again, this is assist. This is assault. Don't be cupping nobody's titty. You catch a case out here.
God, I'm happy because I see it in the field all the time. They took it on the bread and it kind of like slapped. And they did just like this. And they slapped in the face.
So her titty slapped in her face. That's the thing. It do be happening like that. Now, let me give you a quick. I ran a lot of calls in Buckhead. All right. This is not your partner's or anybody else's invitation to the peep show. Explain what I mean. Hi.
I ain't gonna lie to you. I get the hell on. If I'm not the one doing the deeds, I just.
Fair. If you have a partner that's female, you can do that. But what if you don't? What if it's you and Stafford? Try and get her to manipulate the tissue. But again, modesty's out the window. And again, that Buckhead district Friday, Saturday nights, it ain't all bad. But it's not your or my invitation to the peep show. So if I can preserve modesty, I will. What does that mean? A sheet on the back of the ambulance. What does that do for me? Closes those looky-loos off. All right. And also, you don't actually have to expose tissue. You can just have them manipulated out the way. Unless it's Meemaw and that thing's sagging to the floor. That way, they may have to move it out of the way, throw it over their shoulder, whatever. Now, is accuracy impacted by body anomalies? It is. So, in a patient that has an atypical type of presentation of their body structures, what do I mean by that? Again, shamu. Or they have some type of structure in the way, you know, like a growth or something. That will affect your reading. So in that case, just be as accurate as possible. Just be as accurate as possible. So if you wanted some knowledge of where to actually put these things, O'Neill, we're talking about V1 to be at that fourth intercostal space. If you want to be absolutely sure, collarbone, we got 1, 2, 3 down between those two. That's going to be right there in that fourth intercostal space. If you want accuracy, you find the collarbone, you dig down and you find those ribs. You go down to the fourth intercostal space if you want actual accuracy. That's what should be happening, is it? Look what you're learning in paramedic school. It'd be hard to feel on some people, you know, especially they're, you know, hey, ain't feeling. Again, as close as possible to what we're asking here. Again, body tissue does play a role. It does get in the way. It is a thing. It is a thing. So, fourth intercostal space for V2, left sternal border. So again, come down, find the fourth intercostal space. 1, 2, 3 to the 4. And then what? Thank you. You get me. All right, where does V3 go? Between V2 and V4, anterior wall. And V4 is going to be about that fifth intercostal space, mid-clavicular line. Mid-clavicle goes down right here, right at the nipple. Unless the nipple be sad and be like looking down. Sometimes nipples look down. If they're old nips, they're going to look down at the flow. Things start to droop as we get older and they're right high. So the contiguous leads. What does it mean to be contiguous? Oh, tell me something about it. Not continuous, contiguous. Here you are sitting next to me. So these are leads that view geographically the same area. Contiguous means they view the same area. So I'll give you an example. Leads 2, 3, AVF all look at the inferior portion of the heart. Leads V5 does not look at the inferior portion of the heart. This is used for localizing areas of ischemia, injury, infarct. It's also helping you to narrow the scope for yourself. So again, when I teach you how to read 12 leads, I keep it very simple. Matter of fact, I'll give you a quick little look at it right now. That way you can, what? Wait, what am I waiting on? I ain't in a little rush. I'm trying to get y'all out of here so I can go home. Sick of y'all. Is everybody ready? Okay. So the example I'll give you is I'll give you a taste of 12 lead reading right now. That's not going to work. I need a different. I see all leads. I see all leads. I is where we have leads 2, 3, A, V, F. Septal leads, I see V1, V2. Anterior leads looking at V3, V4. And the lateral leads are V5, V6, leads 1, and A, V, L. So if I'm looking at the heart and trying to determine what contiguous leads are, I'm looking at the heart to see if any of these line up and match. I can tell you now that reading EKGs is really just pattern recognition. It's memorizing set amount of criteria and then pattern recognition. It is all about the pattern. And when there's a break from the pattern, we see one of these things is not like the other. And again, I'll spend a lot more time on this when we hit cardiology 4. But just to give you a taste, that way we can talk about contiguous leads so you know what I'm talking about. This is how you would begin to interpret 12 leads. And does that mean you can write I see all leads on your EKG paper? Yes. For quite a while, when I was a brand new medic, I wrote this on every 12 lead I printed out to make sure I was evaluating them. And when I evaluate a 12 lead, I do it in sections. I have a set methodology to evaluate a 12 lead. I find the underlying rhythm first, and then I look at it in sections: inferior, septal, anterior, then lateral portion. Inferior, septal, anterior, lateral portion of the heart. Inferior meaning the bottom, septal meaning the middle, anterior meaning the front, lateral meaning the side. And again, we don't typically evaluate the posterior portion of the heart, which will be done with AVR. So it's not even an issue. But what if I did want to evaluate the right side of the heart? If I wanted to look through AVR's lens, if I wanted to do a right-sided EKG, how would I therefore then do it? Is everybody ready? You really just move things over a bit. That's used to evaluate the electrical activity on the right side of the heart. This can be useful if a patient has a condition called dextrocardia. What is that? The heart's flipped. The great vessels are flipped. Everything's over here on the right side versus the left. So again, you would just pretty much put everything on the right side of the heart. Precordial leads are placed on the right anterior thorax. Wait, what are precordial leads? Tell me about it. Tyler,
Sorry, I'm just writing. What do you say?
what are the precordial leads? V1 through V6. They look at the heart from a horizontal plane. Do the limb leads actually change? No, they staying right there. Limb leads ain't gonna move. I'm still looking at 1, 2, 3. You good. So who's gonna change? V1 through V6, and that's just gonna swap them over to the right side. But wait, there's more. Billy Mays here, guy. Bring you a good, exciting condition of OxyClean. What? Don't look at me like that. You notice the similarity? The beard? Yeah. I've had a lot of EMS nicknames. That was one of my first ones.
Wow.
Turbo, Billy Mays. I'm not gonna tell you that one. No, thank you. Ready? What about a poster EKG? This is gonna look at the back. So that means we're just gonna put 3 precordial leads on the back. We're gonna space them out farther and take a little bit more of a look. Evaluates the left ventricular posterior wall electrical activity. Here's the problem though. You see at the bottom there, V7, V8, V9. Do you carry that? So I mention it to you because why? The National Registry asks my students these stupid questions that have no bearing on what they do. You know what else they ask? They ask about 15 and 18 lead EKGs. Do you know why? Because somewhere out there are services that do those. For their service area, it might be applicable. But for me and you and we and us, is it applicable to do an 18 lead EKG to further confirm the patient might be having a STEMI, or does it make more sense to take them to the ER and have them treated and reperfused? You tell me. Vote. The The ER, the is where they need to be. Remind me of that chef from the Muppets. What if the Swedish people like really pissed off and offended from that? We do not talk like this. How's everybody doing? Feeling good? All right, so let's review real quick. Tell me about the unipolar leads. Not.
Unipolar leads.
Oh yeah.
What are they?
Yeah, what are the unipolar leads? What are they looking at?
They are the view on the horizontal plane. They are your V1 through 6. And one.
All right, so V1 through V6, and they're looking at the heart from a horizontal plane. So that leaves left the limb leads, which are going to be what leads, Baker? AVR. Very good. And they're evaluating the heart and looking at it from what other angles? All the rest of them, top, bottom, left, up, down, all that mess. Now let's get spicier. The EKG graph paper is standardized to allow comparative analysis. What does it mean, comparative analysis, Tyler? Okay. Fair enough. It's standardized so I can analyze the EKG and look for those pattern breaks. All this is breaks in the pattern. This is pattern recognition. It moves across the stylus at a standard speed, and the amplitude of the EKG is deflection standardized. What does amplitude mean? How high the spiky thing is. To keep it simple, how big or little it is. Interesting. So, EKG graph paper is divided in grids of light and heavy lines. You can miss those grid lines by going too fast. Do it right or do it twice. Can your misinterpretation lead to a maltreatment of a patient? You're supposed to zig and you zagged on that one. That's absolutely true. You are supposed to do this in the presence of this, but you did this because you interpreted it wrong. So let's do this. Take your time. Follow your 5 steps I'll give you today. Do not make mistakes if you can help it. Measure twice, cut once. What does that mean? Look at it twice. So what do all these little waves mean? Let's talk about it. The P wave is atrial depolarization. The P wave is atrial depolarization. What does that mean? It means the atria is getting electricity sent through it, causing it to contract, hopefully, because again, we're only looking at the electrical output of the heart. Now, the QRS complex is the big spiky thing. And yes, I use words like big spiky thing because you are a fireman, most of you. I know my audience. That represents ventricular depolarization, which means electricity is traveling through the ventricular myocardium, hopefully causing contraction to occur. Now, the T wave represents what? The ventricular repolarization. What's that mean in less fancy terms? Pretty much a recharging, where again, the sodium is running out of the cell, potassium is going back in, and calcium is going back out. The cell is returning to a excitable, polarized state. Now, a U wave is a less common, very, very less common abnormality that is found. A U wave indicates hypokalemia. Hypokalemia, which means what? They have low potassium levels. We'll see EKG changes if they have high potassium levels in the form of peaked, tinted, spiked T waves, widening QRS, and the possible presence of a sine wave. And then the patient will go into spontaneous fibrillation. Negative. But if they have low potassium levels, they could develop a U wave. More on that later. So PQRST is your normal. U wave is abnormal. So what is an EKG baseline? What is the isometric line? Well, to keep it simple, the EKG baselines represents a generally flat horizontal line where all of these electrical impulses generate off of. So see that little red line up there? That's the isometric line. That is baseline. That means represents 0 electrical energy. And any deviation off that isometric line represents electrical activity in the heart. So baseline, or the isometric line, is that flat line that the EKG will come off of. So any questions about any of that? Come on, y'all got to have some question. No questions? We're getting to that.
Are you gonna go as deep as this one with reflection against electrical?
You're talking about vectors. We're going to talk about vectors and the positive and negative deflections and why that occurs. And it's simply because it's traveling towards a positive or a negative electrode, or the directional flow of the heart So if it's got a negative deflection, that means it's traveling towards the top of the heart. If it's got a positive deflection, it's going down this way like it's supposed to. But for some reason, if it's traveling back this way and depolarizing the heart, it's going to have a negative deflection. Some people have that naturally normally, or there could be some type of aberrancy or dead tissue or damaged tissue that it's trying to travel through but cannot. Depends on the lead too. Yes. Absolutely. So EKG concepts, electrical impulses moving towards a positive electrode produce a deflection above baseline. As I just said, you impatient people. Now, what about an electrical impulse moving towards a negative electrode? Produces a what? Deflection below baseline. So if baseline is the flat line, that means that if it's got a negative vector, it's going to be pointed down. If it's going towards a positive electrode, it'll have a positive vector. It'll be pointed up. Most EKGs you evaluate will be what? Traveling towards a positive electrode, giving you a positive vector. Make sense? No. Does it?
Negative goes down, positive goes up.
I know, but I was making sure it's a room full of fire. Hose dragging, ooh. Surround and drown, guys. Ooh. Friction loss. What's some other terms y'all know? I know words too. What's that?
What's stuff in the rest?
All right, there you go. Wet stuff on the red stuff. Hit it hard from the yard, boys. Oh wait, that's Cobb County. Roswell. DeKalb. Hit it hard from the yard. Yeah. Y'all go interior. Do you really? Is there offensive posturing? Are you making pushes in hallways? I don't know. I don't know. I don't know. Money's money, right? I fight what you fear. Woo! I got blinky lights on my truck. All right. Woo! Very good. All right, so let's look at an EKG. Kapowza. The paper moves at 25 millimeters per second. It's always going to travel left to right. And it's usually either a heated writing tip or ink writer. Now, you can probably guess that most of these are just heated writing tips. Why can you guess that? Because you've never had to change what? The ink. So it's a heated writing tip. Time moves which way? Left to right. Paper moves to the left. Time intervals are going to the right. And time does matter. When we're evaluating, there's other ways to do it, but I'm going to teach you one way. When we evaluate an EKG, we're going to look at 6-second strips to evaluate what rate, rhythm, quality is. Because I just think the math is so much easier on that. And I know how some of y'all really need math to be easy, right? Right. Mm-hmm. So graph paper moves at 25 millimeters a second. And what do these boxes mean? Well, damn it, Bobby. There. So these boxes, these one tiny little box represents what? 0.0004 of a second. Which means that, are you at them? I might want to save that.
We're running out of paper, bro.
Huh?
I didn't do this. I'll give it to you.
Give it to me. So that means that every one of these little blocks could matter. That means that 5 of them would equal 0.20 of a second. 0.20 of a second. So one of these blocks is 0.04, and one large box is 1/5 of a second. So how many fifths of a second will make up a whole second? 5. Math, easy. Okay. So we're representing electrical timelines, like how long it takes an impulse to travel. That's why we have graph paper with little boxes, and we can take out our little calipers. But you know what works good also? The head of a pen. Personally, I like calipers, but again, they can poke you. And I hold grudges. So after it poked me once, I quit carrying them. So carrying this right here, I'd count 1, 2, 3, 4, 5. And that is 0.20 of a second. The vertical axis represents amplitude, which is what? How tall the wave is. How tall the wave is. So you can pass this around if you've never seen one and look at it and see what we got going on. Well, do what? Actually read these things correctly.
With that.
Good thing, you're gonna be a good paramedic.
Johnny, are the graphs, is that the same as one of grading? Is you ready to look at grading?
It doesn't matter where it comes from. The graphical paper and readout's gonna be the same. Each block will be 0.04 and a big block will be 0.20. Doesn't matter what EKG you use. So if one big block is 5 small blocks, it makes up the big block. That's 0.20 of a second. So how many of those would it take to make 3 seconds? Okay. If you're ever in doubt and you want to know what a 6-second strip is, now me personally, I can eyeball it and tell you what 6 seconds is. But you, if you ever get stuck, just count 30 boxes. Count 30 big boxes. That's 6 seconds.
What's good enough?
Good reading, you're going to do a 6-second strip. You can get all you need from a 6-second strip. You can get rate, rhythm, quality, and then you can evaluate the presence of an infarct. When you hit 12 lead, it's going to give you that big long printout. So that's another thing, whole another thing. But my advice to you, my friends, is before you do a 12 lead on anybody, do the standard limb lead 1, 2, 3. Why? The 12 lead has a lot of noisy data, and you can't always get the underlying rhythm with the 12 lead. Why? Because it's got these cutoffs before it goes to another lead, does it not? It's less than 3 seconds. I can't evaluate what the underlying rhythm is. So let's say, I'll give you this example. This patient right here in my mind is exhibiting a sinus rhythm with a rate of 85 with a possible anterior portion of the heart MI going on. Learning how to piece this together with your words is going to be probably the most challenging part for some of you, but there's an underlying rhythm and then there's ectopy, or in addition to. So the guy is having an anterior MI, right? But the underlying rhythm is that he still has a sinus rhythm. It's got a rate of 85. Everything's perfect, except that over there in the anterior portion on leads V3 and V4, he's got ST elevation. Everything else is fine. It's just that anterior portion of the heart. But the underlying rhythm is, it would be normal sinus if it was normal, but because he's got an anterior MI going on, it's now a sinus rhythm. Because is it normal to have anterior MIs going on? No. Is it normal to have the ST elevation go on? No. So the PR interval. The PR interval. We'll finish this and we'll go to lunch. But if you're watching online or on the video, no time will elapse for you. The PR interval includes atrial depolarization and conduction of the impulse traveling through the AV junction. So basically, we're seeing how long it takes the impulse to travel from the atria to the ventricles by evaluating the PR interval. What is an interval? A time frame. So a normal PR interval is 0.12 to 0.20. If they're 4.04 seconds apiece, those little blocks, we have either a 3 to 5 block normal. If it's less than 3, it's firing too fast. If it's more than 5 blocks long or greater than 0.20, 0.20, then we have a delayed PR interval, and there's something delaying the conduction from the atria to the ventricles. Let's do that again. The PR interval is the P wave length all the way to the beginning of the QRS complex. It is evaluating the length of time it takes for the electrical impulse to travel from the atria to the ventricles. Normal PR interval is 3 blocks to 5 blocks, or 0.12 to 0.20. Who's lost? 3 to 5 blocks. I knew that'd work on some of you. Did I? I meant to. Sometimes it's more fluff. Y'all have already seen that representation before. I had it in cardiology 1. I didn't feel like beating the dead horse. 3 to 5. 3 to 5 boxes. So next we'll evaluate the QRS. So the QRS complex represents what, who, when, and why. We're talking about it being the representation of the depolarization of the contracting ventricles. So you must have electricity for the meat to beat. Electricity hits the meat, causes it to expand, contract, and then push blood out. But again, the EKG is only the electrical graphical representation of the heart's conduction system, not an actual representation of the mechanical beats. How do I measure the mechanical output of a heart? Owen high. A pulse, very good. A blood pressure. So the QRS is from the beginning of the Q wave, creates 2 sharp pointed wave, indicates the pulse has proceeded normally. But again, how can I really know that for sure if I'm not checking mechanical pulse behind it? Within the first 30 seconds of meeting a patient, you should have already had your hands on them and had a pulse check done. What if they're conscious and talking to you? Within 30 seconds, still put your hands on them. Feel their pulse. It's bounding. It's thready. It's normalness. It's regularity. And within 3 to 5 minutes of meeting a patient, you should have obtained an initial broad baseline set of vitals that includes, but not limited to, a 12 lead. Act now. So the Q wave is who? The first negative deflection. Needs more time? Yes, sir. The R wave is the first upward deflection. And the S wave is the downward deflection. It all comes to make that spiky triangle thing. QRS. The direction of the amplitude depends on if it's going to a positive or a negative lead. So that'll be the vector. Again, most of them are going to be traveling the normal conduction pathway and will be upright. If it's traveling backwards for some reason, it should be pointed towards a negative lead, then it will be deflected abnormally and downward. And again, certain leads will have that look to them anyway. Give you a second to keep making your notes. We'll keep on keeping on. Oh, well, this book actually has a companion website with the access code inside. Oh, there's the access code. Sure hope somebody makes the highest score on the mod exam and earns their book. It'll be probably in May. Yeah, y'all got a while. All right, moving on. So we talked about the Q wave being the first negative deflection, R wave first upward, S wave downward. Now the J point is where QRS complexes end and the ST segment begins. So if QRS, if this portion here that we're talking about is the QRS, we have the Q being here, the R being the spike up here, and the S being the ending point of this triangle looking thing. The ST segment is the length of time it takes for the impulse to finish depolarizing the myocardium of the ventricles. And then the T wave here represents repolarization of the ventricle. So the S to T segment is a measurement of what? How long it's taking the ventricles to repolarize or recharge or reset. So it's taking these guys a second to do that. Now the ST segment is also useful for what? Evaluating some myocardial infarctions. So when we say we have ST elevation, this segment right here is what will start to elevate off the isometric line. And elevation of even just one block in 2 to 3 congruent leads indicates some serious myocardial infarction and coronary issues. Now, what does congruent mean, Thornton? Okay. Oh, I couldn't hear you. You were yawning.
Oh, contiguous leads, so like 2, 3, yeah.
Okay, so contiguous leads means that they're looking at the same geography. So 2 through AVF will be looking at the inferior portion of the heart. If 2 and 3 are both saying there's elevation of even just one little block, and how much is that little block worth, Gabe? 0.04. Even one block is serious enough to call a STEMI alert. Now, a lot of times you won't see just one block. There'll be several blocks, but even one is significant. That goes for your cardiology lecture. That goes especially for your Fulton County guidelines. That is actually written in your clinical care guidelines. So where's the J point? The J point is going to be listed right there. QRS, and this is that segment right there. That's where we begin looking and evaluating for the presence of ST elevation or infarct. All right.
For on the biphasic waves, is the J point where it crosses the baseline the first time, or when it comes back to the baseline? Is it at the end of the complex, or just where it crosses?
So when the QRS complex ends, that first return to the isometric line should be the J point.
What I'm saying is if that S wave were to go past the baseline
And deflect negatively?
Before it came back up, would the J point be the first pass or the second pass?
Second. Very good question. T wave again represents ventricular repolarization. The first half of the T wave is your absolute refractory period. What does the absolute refractory period represent there, Tyler? Okay. It's close. Very good. So the absolute refractory period means that absolutely no other stimuli can depolarize or affect the heart while it's in this phase of repolarization. Now, the last part of the T wave, the relative refractory period, is a danger area. Why? A strong enough stimuli from outside sources, such as if I punch you in the chest for getting a question wrong when I ask you in class, it could stop your heart. Anybody heard of the DIMMOC, the death touch? It's not, the finger punch thing. It's like kind of like a kung fu mythology thing, but also like it's not completely out of the realm of possibilities. You know, I'm not sure how they'd be able to just like time it perfectly, but like I've seen weirder things, honestly. But it's not out the realm of possibility. Because it wouldn't take a whole lot of force, would it? Just enough at the right spot, the right time, more about precision than strength. And wasn't there years ago a time and a place for the precordial thump? Is that what you're about to say? I've seen it work twice. And one of the times, I'm not even sure it was a precordial thump. Me and my partner Shay in Montezuma, Georgia. That's right, the Mennonites. Woo! Ting. This guy was like in front of us talking crap. He'd been shot by, several times, and he just throws his head back and he goes into PEA. And Shay, being the big maternal mama type, was like, "Oh no, baby!" Reaches back and slaps him in the face. This summer gun came back to life. Who the hell hit me? Most weird. Them healing hands got him. Yes, Miss Shay. It wouldn't happen to me, right? Why's your fist closed? I don't know. I can't explain that one. Maybe you can. It was trippy. I'm like, am I just tired or that really work? So, yes. He went into cardiac arrest. And she said, "Oh, hell no, baby." Slaps him in the face. He came back to life. Whatever, it worked. Don't be doing that though. Let me go ahead and just throw that out there. Don't be slapping your patients. Down in South Georgia, there's a lot of autonomy. You know, if nobody's keeping track. So what is the relationship to electrical events in the heart? Oh, Lord. The QT interval. Q to the T represents the total duration of ventricular depolarization. The Q to T interval represents the total duration of ventricular depolarization. Now, a prolonged QT interval increases the risk of ventricular arrhythmias and sudden death. Can you think of some things that can cause a widened QT interval? How about tricyclic antidepressant overdose? Usually turns into torsades. How about Zofran? Ooh. That's why you should be doing 12 leads on your patients before you give them Zofran. What else? How about hyperkalemia? All this could cause a widened QT syndrome, which would cause the patient to be at a very high risk for VFib, which would put them at a very high risk for sudden death. That'd probably help. So, QT syndrome. We talked about the refractory periods. Somebody explain to me what the absolute refractory period is. What you got?
Ventricular repolarization.
Okay. So the repolarization of the ventricles during the absolute refractory period means what? No outside stimuli can cause a secondary impulse to be generated. All right, what about the relative refractory period? Very much so. Absolute means no go. Relative means, yeah. Good enough hit at the right time could cause it. So during the relative refractory period, strong stimuli could produce a depolarization. So ST segment, myocardial infarctions are producing changes in that line. In the ST segment, where do I start evaluating the ST segment at? The J point. We have layers, donkey, 3 layers. Ischemia, injury, infarct. Ischemia, not enough oxygen. Injury, the tissue's actually being damaged. Infarct, the cells are dead and necrotic. Dead necrotic cells. So remember how we had like some levels to the respiratory distress? You had respiratory distress, failure, and then arrest. From going from bad to worse. Bad to worse for your MIs is ischemic tissue, injured tissue, infarcted tissue, because infarct means dead. So relationship to electrical events. Leads V3 and V4 look at the anterior surface of the heart. V1, V2 look at the septal. 1 AVL, V5, V6 is lateral. And 2, 3 AVF show inferior changes. Or if you wrote down what I said earlier, I see all leads. 2, 3 AVF, V1, V2, V3, V4, V5, V6, AVL, and 1. You've got it in kind of a sequential order. For me personally, if things are in a sequential order, it is easier for me to remember them. Anybody lost so far? Hey, do I need to slow down and go back?
You just have to read the shit at the same time.
Well, there's an option there. So more relationship to the EKG and electrical events. Medical procedures and drugs used to treat myocardial infarctions, they've all come to the same realization. All the studies point to the earlier the initiation of the treatment, the better the patient's potential outcome. So what does that mean for you, paramedic student? That when you get on scene, take them to the hospital, don't be playing around. When it comes to trauma, that's a surgical disease, meaning that it needs a surgeon. No need you playing on scene being rescue Randy. A patient with chest pain, that's a cath lab disease. It needs a cardiologist. Yes, you can give them drugs and mitigate some of the circumstances that they're facing, Aspirin stops the clot from getting bigger. True. Nitro vasodilates, but it doesn't remove the clot. It doesn't pull it out. It doesn't form a bypass around it. It does not reperfuse the myocardial tissue. You've at best taken some workload off the heart and put a little bit more blood flow to it. So any chest pain or trauma patient, or most patients in general, 10 minutes or less. Why would you deviate from the 10 minutes? What do you think there, Thornton? Clear EKG. Okay, I want that. What else? Patients in cardiac arrest. That changes things. There are several studies to collaborate that if you stay and work it a little while, you have a better chance of resuscitating. It's about 13.1% higher chance, actually. Because we ain't got to keep stopping and starting, trying to move them around and down. Why else? How about just terrain? If you go up 4 or 5 flights of stairs and you have to pick SHAMU up and take them down 4 or 5 flights of stairs, that 10-minute window's over. Might take me 10 minutes to get up there. Stairs. So that's something to think about. So why and how and what do we need to do to learn the EKG analysis technique? I give you a 5-step process. Follow it, be successful. Don't follow it, fail. Simple? Let's do it. Evaluation of a patient's heart rate. Then heart rhythm. P wave. PR interval. And then the QRS complex. Let's do it again. 5-step process. The heart rate. The heart rhythm. The P wave. The PR interval, which again is the interval where the impulse is traveling from the atria to the ventricles. Then the QRS complex. QRS complex. Do you know how you'll be successful at this? Repetition. Repetition in a systematic approach. I just gave you the systematic approach. Not to say there are not other systematic approaches. There might be better ones. There might be ones more suited to you and your learning style. This is the one I know. This is the one I teach. This is the one that's been successful for me. Also, it seems to me the simplest. And I can tell that most of you need simple. Right, Hammer? There it is. So rate, rhythm, P-wave, PR, and QRS complex. Some more general rules I'll give you. Is everybody on the notes? Cool. Some more general rules to follow. First and foremost, look at your patient. Look at your patient. If the monitor says VFib and they're talking to you, they're not in VFib because that means their heart's not beating. If they're in VFib, that means there's no contraction. But if he's like, yeah, the Braves gonna kick some booty this year, man, hell yeah. I'm gonna get me a beer and a hot dog. If he's talking to you, then it's possible that you have a lead loose, there's artifact, maybe the patient's shivering and they're cold. You ever picked up a urban camper during the wintertime? What are they doing? Shivering usually because they've been out in the cold all night. Read every EKG strip from left to right. Start at the beginning of the strip. I'll give you a tip, something I like to do to students. You know, I'm tricky. There's a certain EKG test that sometimes will pop up, and one of the rhythms is upside down. And a lot of students don't turn it right back side up, so they get it wrong. People will hand you just an EKG strip, and you're like, it's hard to read. Oh, better. It's that simple sometimes. Left to right. Make sure that the strip is upright. Apply the 5-step systematic approach. Don't skip a step. You might be tempted to try and skip a step if it's a big, obvious kind of one. Like monomorphic V-tach is pretty obvious, but please take your time. Registry is tricky, and so am I. Avoid shortcuts and assumptions. A quick glance will often be wrong, especially if there's the subtleties I like to sneak in there. Like what? A first degree block is simply what? PR interval is a little bit longer. If you're not counting those little blocks, I'll sneak one past you. And guess what that means on your paper? X. Ask and answer each question of the 5 steps. Question 1, what is the heart rate? Question 2, is it regular? Question 3, what does it have a P wave? What does it look like? Is it upright and perfect and pretty, or is it inverted or missing? And then the most important one is to master the accepted parameters for each dysarrhythmia and then apply all the steps. Because as you apply the steps, you get a rate. Rate gives me inclusion, exclusion criteria. If it's over 100, I can exclude any kind of bradyarrhythmia, right? If it's irregular, that excludes any kind of normal sinus thing, right? That means it's either going to be a PAC, PVC, PJC, an AFib, or something that would cause an irregularity of the complex arriving at the same time every time. So mastering the parameters will allow you to do what? Did you remember how I drew on the board trying to form diagnosis? I'd say, all right, that's a point, and then I'd draw a diagnosis over to the side. The same thing can apply to you. If I was to say, well, this rhythm is irregular, has chaotic baseline, no discernible P's, that's 3 criteria. Who's that pointing to? That points to AFib. That's how you identify these things. You find the break in the pattern, make a note of it, and then line it up with who it makes the most sense with. Sound good? Love it. Now, evaluating the heart rate. That is the number of electrical impulses represented by the PQRST, PQRST, PQRST. So, in 1 minute, we're seeing what the rate is. You have an atrial rate. And a ventricular rate. Here's what you do. You count the atria too. What does that mean? You count the P waves in a 6-second strip. You count the QRS complex in a 6-second strip. Why? See if they're different. Is there a 1-to-1 ratio? There should be 1 P wave to every 1 QRS. Dang it, Barbara. Better? The A to V ratio should be 1-to-1. Later on in the slideshow, I will show you an actual, you know what? You might have been there. Actually, that call I ran and I yelled at y'all about, whatever, allegedly. Told y'all to get, are you sure? It was at the Women's Center though. This lady was having, anyway, I'm gonna show you an A flutter with a 6-to-1 AV conduction ratio, which means there are 6 flutter waves to 1 ventricular contraction. It's not in here. It's actually from the Grady Zoll monitor. I took a picture of that. Oh, that's interesting. Material. So make sure they match 1-to-1. Count the P waves, count the QRS complexes. On average, the SA node discharges 60 to 100 times. If it's less than 60, it's called bradycardia. If it's more than 100 mile an hour, it is called tachycardia. There is a reason for it to be below 60. There's a reason for it to be above 100. Is it drugs? Is it CNS depression? Is it poor conduction through the AV node? Like, there's a reason. Find the reason. Well, she was just in a car wreck. Yeah, it could be she's just excited and has anxiety, but it also could be because she's in her shock response. One of the first things that happen in shock is what, Owen? Fast heart rate. Why? Compensating. That's right. What does it mean to compensate? Gabe, tell us about it. Yes. It means to make up for the lack thereof of something, right?
Just before, we're even the heart rate from the number that it gives, not by reading the actual strip rate.
Yeah, don't read the strip. You count the waves yourself. Because the strip's going to give you, well, the heart rate's 65. It could be right. Count it first, and then use it as a diagnostic tool to confirm what you already know. Does that make sense?
How do you count the heart rate on the plate?
I'm about to show you. So we have the 6-second method and the R to R interval method. The 6-second method is what I teach. There are other ways, but they seem to me more complicated. Here's what we do. We have 6 seconds on the EKG strip. How do you know what a second is? Well, a lot of times there'll be bold lines up here. So 1 second is how many blocks? 5. So 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Also, most of your EKGs, look on them right there if you got one in front of you, have these bold lines. This represents 1 second. The bold line represents 3 seconds. The bold line, if you have 2 of them, means 6 seconds. So how, therefore, do I calculate a heart rate based on 6 seconds of data? What? Are y'all mathematicians? So how many of them complexes are they? Times 10. Let's do it. There's 1, 2, 3, 4, 5, 6, 7, 8 times 10. That's a heart rate of 80. Hard? No. How many big boxes does it take to make a 6-second strip? 30. If you ever get stuck, do that. I'm at the point now where I can just kind of eyeball and know where 6 seconds is at. But if I get lost, there's bold and lines. If I get lost, I can count 1 second or 3 seconds, or I can just count 30 boxes and have a 6-second strip. Another example. Let's do another one. Hi. We have 1, 2, 3, 4, 5 complexes in 6 seconds. 50. What did we not do though? Atrial rate. Does it match? Is there 50 atrial contractions to match the 50 ventricular contractions? Let's see. 1, 2, 3, 4, 5. Yes. So we got a 1-to-1 AV conduction ratio. Sounds good, right? Now, there are more complicated methods, like the 1500 method, where you're going to be doing what? Count the number of small blocks between any complexes, divide by 1500. Which one do you like better? What? I got to divide? Hell no. Let's go back to the other thing. Yeah. 6 seconds. Number times 30 or number times 10. So how do I find 3 seconds? Bold thing if it's there. So 5 big blocks. Is that 3 seconds? 1 second. Is it?
No.
30
bucks. 5 little boxes.
15.
All right, there you go.
15 blocks.
So if you want to find 3 seconds, do 15 blocks. If you want to find a whole 6-second strip, then you do 30 blocks. And then you just count the number of QRSs, count the number of P waves. Anybody lost in the sauce? If there's not a P wave for every QRS, we're looking at a criteria for it to be certain rhythms. I'll give you an example. When we talk about junctional rhythms later this week, we talk about rhythms that are generated at the AV junction right here at the bundle of his. So if the impulse generates here in this area and signals down, what might you not see on the EKG? You won't see a P wave. And if you do see one, it'll be inverted because it will depolarize the atria via retrograde depolarization. Why is it inverted? Why is it upside down? It's pointing back towards a negative lead. Oh. Remember, you paid for this. You chose this for yourself. So, best way for me to evaluate a heart rate. Gabe, tell me about it. Say it again for me.
Count the QR codes, count the-
Count the P waves, count the QRS waves, multiply by 10. That's your rate. Everybody with me? And what about the rhythm? Rhythm is.
They all look the same.
Or is it regular or rhythm? See if I can do it. The rhythm is checking out, just holding it, pushing them, in the pulse.
Anybody want to try the 1500 method? Me neither.
I did.
You did it?
It's, you divide the number, you divide 1500 by the number, not divide by 15.
Still sounds a lot more work.
More concept.
Well, a lot of us didn't go to Georgia Tech, okay? Well, okay. All right, so heart rhythm. Is it regular? We have classifications of regular patterns, intervals of R waves, irregularly regular, and regularly irregular. Let's do that again. Is it regular? Where the spiky things are the same distance apart every time? Or is it regularly patterned where it has an opportunity for us to see a pattern of when it becomes irregular? You want an example? Okay. Every other beat produces a PVC. So normal rhythm, PVC. Normal rhythm, PVC. That's called ventricular bigeminy. It's irregular, but it's patterned. It's regularly irregular. You can pattern it. That makes sense? What if there's a PVC or an irregularity every third beat? That's called ventricular trigeminy. Every third beat is an irregularity. So it's regular, but it's regularly irregular, which means it follows a pattern of being irregular.
So there's just a random P wave every time. It would be irregular.
Yes. If it's irregularly irregular, it's just that there's no pattern to it. It's just kind of chaos. This is where atrial fib comes into play, because all the cells of the atria have pulled out their guns and they're blitzing the AV node. And he's just like trying to be a goalie and he's stopping as much as he can. But it means that the atria are having multifocal atrial blitzing, which means they're just sitting here doing like this. They're not pumping anymore. They're not pumping anymore. So that's where we have the irregularity of the QRS complex. That's why it's short, long, short, long. It's all over the place. It's not something I can measure. So when I am measuring regularity, I'm looking at the R to R interval. Why did I have the calipers earlier? Pow. Make it easy. You know what else you can use though? The back of some EKG paper. What do you mean, Josh? Well, let me show you. Who's got a piece of paper? Oh, I do. So you can take a piece of paper and do a mark. Boop, boop, and then march it out. March it out. Make sure it's irregular. If it's not, you'll see it. You don't have to have fancy calipers that stab you in the finger. You can use just a piece of EKG paper. Make your marks, then march them out. Is it regular? Is it the same distance apart every time? Is it the same distance apart every time?
Is it like a confidence interval for that? Like when it's just slightly.
0.06.
1.5.
Yes.
1.5 blocks.
If it's within 1.5 blocks, it's still considered regular. If it's beyond that, it's like 2 blocks apart, it'll be considered irregular. So tell me about it. Measure the intervals there. Let's start with rate. Gabe, what you got? And how do you know that's a 6-second strip? You got the little bar down there. So we know that's 3 seconds. So that's a 6-second strip. What's my rate? Atrial. Yeah. Now what's your ventricular rate? Okay. So you have an AV conduction ratio of what? 1 to 1. You should have 1 P wave to every QRS. That's normal. If you had 2 or 3, that'd be abnormal. It'd make me think of a second-degree type 2 block, because one of the ways you can tell a second-degree type 2 block is that it's got a bunch of P waves just running around, all unconducted and stuff. All right. Next, how do I measure and gauge that is regular? What do you think? So you got a choice there, O and high. You can actually count the little blocks in between and make sure that they're all the same number of little blocks apart. Or you can do like I did, take a piece of paper and mark your blocks lines and then just kind of march it out. That makes sense? I have an EKG game that I'll play with you at some point, but it's pretty much a PowerPoint show of all of it. So as we said earlier, if the interval is less than 0.06 or 1.5 small boxes, we can consider it to still be regular. It's still regular. Regular. All right, so we talked about the regularity, the irregularity. As long as it's about within a block and a half, we can deal with it. Okay. As long as it's pretty close. So deciding, is it regularly irregular or occasionally irregular? These are what we got to find out. Is there a pattern to the madness? Or is it just chaos? Chaos would be what? Chaotic baseline. It's fibbing because it's not regular. It's not consistent. So it's fibbing. There it is. So let's take a look at some. You ready? Boom. Are either one of these things regular? That'd be a no. That would be a no. What's that? Tons of little things can make that. Just the patient's tissue, you know, their electrical conduction system, way it's structured, and whatever's causing them to be irregular is probably causing that depression in their EKG right there as well. Let's see. Yeah. There's no pattern. No pattern. Next step's the P wave. What does the P wave represent, Owen? Of all right, very good. It represents depolarization of the right and left atria. It's the first deviation from the isoelectric line, which is the baseline, remember? It should be rounded and upright. Why?
Electrical stimulation is going from the SA node.
All right. So if it's rounded and upright, I know it's coming from the SA node. If it looks different, the morphology or the appearance is different, I know it's coming from somewhere other than the SA node. This is called a sinus rhythm. When it comes from the SA node, it's a sinus rhythm. What does it look like? It's pretty. It is rounded and upright. It looks the same across the board. If it looks anything different, is it big? Is it spiky? Is it inverted? It's coming from somewhere else. If it is rounded, upright, and pretty, it is coming from the SA node. So what do I want to know about the P wave? I've made it through 2 steps now: rate, rhythm, quality, and appearance of the P wave. So what am I looking for? Is the P wave even present? Do you have a P wave? Are they occurring regularly? Is there one P wave for each QRS complex? What's my ratio? 1 to 1, 2 to 1, 3 to 1, 4 to 1? Are they smooth, rounded, upright, or are they jagged, bifurcated, pointy, spiky, inverted, missing? Do they all look similar? I will give you an example of why. If you have a 6-second strip that displays 3 different P wave morphologies, you have a wandering atrial pacemaker or a WAP.
That's okay.
Yeah, that's exactly what that means. Would that be a good reason to find out if they are all appearing the same? Because a wandering atrial pacemaker means what? It's jumping around with who's pacing the heart. So the PR, the P wave, is it there? Is it regular? Is it inverted? Is there 1-for-1 ratio there? Is it smooth, rounded up right, or is it goofy looking? Do they all look the same? These are all important questions. It seems to me that you have already figured out you can't just grab an EKG strip and be like, nope, this. Have you figured that out? Why do I feel like I'm gonna have the same conversation when we're reading EKGs? Hey, Thornton, slow down. Don't do that. Go through your 5 steps. You know how I know? Because I do it every year. Every year, I do the same conversations. Hey, slow down. Follow your steps. Don't be stupid. Don't lick that. Blah, blah, blah. What? No touchy. All right, the PR interval. That measures the time interval from the onset of atrial contraction to the onset of ventricular contraction. How long is it taking that impulse to travel from the atria to the ventricles? So, measured from the onset of the P wave to the onset of the QRS. Ooh. Normal, 3 to 5 blocks. How much is each block worth? 0.04. So 4, 8, 12 is normal. 16, 20, normal. 12 to 20 is normal. 3 questions you ask that PR interval. Are they greater than 0.20? Are they less than 0.12? Why will that make a hill of beans to me if it's less than? It means it's traveling much faster through the myocardium than it's supposed to. It means that there's an increased conduction velocity. Why is that? Well, what's a rhythm that we could see? Well, one of the criteria for Wolff-Parkinson-White is a shortened PR interval, a slurred Q wave, and a widened QRS. Looks like a delta tailwing. So we must measure the PR interval. All it takes is you stopping and counting blocks. But what do? We get lazy, comfortable, and we skip it. So what do we miss? We miss first-degree heart blocks. We missed conduction velocity increases. We miss a lot of important data that can help you differentiate between rhythm A and rhythm B. Rhythm A and rhythm B. Rhythm is a dancing. Next, step 5 to round it off. We have the QRS complex. This means that depolarization and contraction of the ventricles has occurred. That means that the impulse has traveled through the myocardium, hit the ventricles, and now we have achieved ventricular contraction. But it's only the representation of the electrical graphic waveform. How do I verify mechanical? Pulse check. And check a blood pressure. Very good. So, represents depolarization of the ventricles. Q wave, first negative or downward deflection. R wave, first upward. It's also the tallest. And the S wave, the sharp negative or downward deflection that follows the R wave. Again, it depends on you and your body. So what questions should I ask of the QRS complex? Are you bigger and wider than 0.12? Are you smaller and more narrow than 0.12? Are all the QRS complexes similar in appearance? Similar in appearance. If the QRS complex is wider than 3 blocks wide, then you know that the rhythm is most likely ventricular paced. That means the origination of the electrical impulse starts in the ventricles. If it's less than 3 blocks and kind of skinny, it's coming from above the ventricles. We have a name for that. Supraventricular tachycardia. It means above. You can always tell who's running the heart. If it's skinny and narrow, it's the atria. If it's fat and juicy and wide, it's the ventricles. Which out of those structures, ventricles and atria, which one's big and juicy? the ventricles. So therefore, the rhythm it produces will be big and juicy. If it is coming from the atria, which are small and skinny, it will be a small and skinny rhythm. Everybody with me? Students every year, bless it. Every year we have students mix up SVT and VTAC. VTAC is big, wide, and juicy, while SVT is skinny, fast, and narrow. Not narrow, narrow. All right, who I want? O'Neal. Jesus Christ. Wrong. Sorry, I was just practicing. You got 5 steps. Run through them. All right, so you found out it was a 6-second strip, therefore it makes everything easier. Okay, go ahead. Do you have 80 atrial or 80 ventricular? Do you have a 1-to-1 ratio? Won't you come to the board and do it? I don't wanna, please no. All right,
Here,
walk me through it.
right here, I have
3 seconds.
3 seconds.
3 seconds.
Okay,
All
so
right.
that's going to give me, 30, I have these 30 boxes, so that's 6 seconds.
6-second strip.
And then what I did, I didn't write down all the rules. My button didn't work. Alright, so I went 1, 2, 3, 4, 5, 6, 7, 8. When I remember what you said, that in order to get within a minute, you want to go ahead and times that by 10. Am I going right?
Yep.
I'm ready. So I got 8 times 10. Now looking, I have a P. Yeah, that's
All right, so we got the rate. The rate is 80. Atrial rate's 80. Ventricular rate's 80. Very good. The next step is it regular? So are the R to R's?
would be because it's in between, so wouldn't that be like the same? So you want like 60 to 100? Are we
Yeah.
doing it like that?
Yeah, so it's some type of normal rate. So it means it's not a tachyarrhythm, it's not SVT, it's not junctional tach. There's a lot of rhythms we can exclude because the rate is nice and 80. Now, is it regular though? Because there's some rhythms that will fall into a normal pattern of heart rate. So is the R to R and the P to P the same length and distance apart every time?
I don't think so.
You don't think so? How would you know if you didn't measure? Either use a caliper or a piece of paper and then march it out. You want me to show you how again?
Yeah. That's what I was having kind of problems with.
So what I need to know is issue. Look. Is this the same length apart as this? Now I'm marching. Perfect.
I see what you're saying.
Perfect. 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 You can do this with a piece of paper, notepad,
I
or
didn't see that.
you can do a piece of extra EKG strip.
Put on a piece of paper. This-
Yeah, make sure it's regular. March it out.
So this is. right.
It's regular. So
Okay.
the rate's 80, it's regular. Now the P waves, do we have them? Yes,
Do we do the same thing?
same thing. Is there a P wave for every QRS complex? Very good. Do they all look the same? Are they rounded and upright?
Yeah.
Okay, now we look at the PR interval. Is it 1, 2, 3, 4 blocks? It's between 3 and 5. It's normal. All right, and the QRS complex, it's less than 3 blocks wide. And it's not greater than 3 blocks. It's got about 1.5 blocks, so that's normal. Everything about this thing is normal.
Okay, so the PR.
Give it a name.
is gonna be 1, 2. How much you got 3 or 4? So that was right here for me.
The start of the P wave is right here. So 1, 2, 3, 4, 5. 5 is perfect. So the rate's normal. The
Okay.
regularity is normal.
Here, 1, 2, 3, 4,
5.
5.
There it is.
Okay, so you don't start like right here, you start like.
Right
Okay.
at the onset of the P wave. So the rate's normal. The rhythm is normal. The P waves are normal. The QRS is normal. The PR interval is normal. Everything's normal. Give it a name. Normal sinus rhythm.
So down, once I get it, I do.
Everybody see how she got that? She went through 5 steps.
I should have told him to shut up, right? Because maybe it's bad, but people-
Everybody, let's hug. Everybody, let's. All right, so seeing all this work out together and be put together is not a one-time process. We're gonna spend a lot more time doing that. And I kind of feel like we should spend more time doing that. I'm gonna go a little bit farther today, cover a little bit more material than the rest of the day. Let's look at some EKGs and just go through the process, okay? All right, so a vector is a diagrammatic way of showing the strength and direction of electrical impulses. We talked about vectors and why a EKG would be upright versus inverted. Upright versus inverted. Do you like pictures? Me too. This helps. When electricity flows toward a positive electrode and away from a negative one, the pattern produced on the graph paper will be upright. It normally flows where? Directionally down. When the electricity flows towards a negative electrode, it will have a negative deflection. It'll be inverted. We're going to talk about axis deviation here soon. That comes later. I don't want to drown you today, but wait, there's more. Make it hurt, Josh. Yes, Daddy. What? Don't tell on me. I don't care. So let's talk about it.
Cause I may have a moment. So.
Uh-oh. An aha moment. Let's talk about it.
All right, so
Believe it.
the negative, that is like the white one is.
Yes. Did we have the aha moment? God damn, I got one.
I didn't realize that they, like the actual, they told you.
Well, when we talk about bipolar leads, they have a negative and a positive on each end. When we talk about unipolar leads, they're just connected to one polarity of lead.
So with the upright or inverted, just with P and the T? Or it be beginning in the Q and the S also?
That also depends on a lot of variables of where the impulse is coming from. Like I said, if a junctional rhythm is originating a impulse from the AV junction, it's below the atria. You will always either have a missing or an inverted P wave because it's going to flow backwards. So it depends on where it's coming from. So another look at the PR interval. From the beginning of the P wave to the beginning of the QRS complex, normals is 0.12, 0.20. Why am I repeating slides? It's a different slide saying the same thing. Why am I repeating it? Oh, repetition. He gets it. Also, this one's got better pictures. I know how High likes pictures. The QRS complex, looking at it, represents ventricular depolarization. It's usually 2 or more waves together. Normal is 0.06 or 1.5 blocks to 3 blocks wide. If it's greater than 3 blocks, who's running the show? Ventricles. Now let's talk about What?
That one, oh, up to 10, 12.
It is.
Oh, okay.
It's like, let's go with 12.
All right, so nothing more than 12. And then
Anything greater than 12 is definitely ventricular involvement. 10, 11, that's splitting hairs, really.
Okay.
All right, Q waves. What is the importance of a Q wave? What can it show me has occurred? So a Q wave having some slight deflection is normal, but a pathological Q wave indicates dead ventricular meat. So if a Q wave is wider than 0.03 and at least a third of the height of the R wave, that indicates a pathological Q wave, which means this patient has dead tissue. That dippy thing right there, let me draw it so everybody can see it.
It's dead tissue because it's a negative.
This thing right here.
Yeah, because it's a negative. Oh,
If you see negative there, it's dead tissue.
If you see a pathological Q wave where it dips down and it's greater than 1/3 the height of the QRS and it's wider than a block and a half, or almost a block wide, excuse me. If it's almost a block wide and greater than a third of the height, it is a pathological Q wave indicating dead ventricular meat. You won't.
Which lead are you talking about in this case? Because a lot of the leads have biphasic waves where it's gonna look like that. But which lead are you looking at?
So if you see this in a 3 or 4 lead, it's definitely meaning some dead meat.
Okay.
But
This
also
is only for
depends.
This is for the precordial.
Some of them do have a negative deflection, but that big, that far, that much, that'd be a stretch. Depends also where their MI was. Did they have an inferior MI? So I would see this deflection where? 2, 3 AVF. Was it lateral? V5, V6, 1 in AVL.
So I'm looking at the QX.
Dead ventricular meat and previous MI history.
So previous. No answer.
Yes. So the ST segment, you have something? All right, let me pause. And we're back, folks. So ST segment, talk about it. So that begins from the QRS complex, beginning of the T wave, should be at baseline. If it's not at baseline, that J point's elevating. What does it mean usually? If I got ST segment elevation, what does it mean? Possible STEMI. So how much elevation is significant? So how many blocks would be significant? 1 block is significant. In what type of leads? Congruent, contiguous leads, which means what? Geographically, they're looking at the same portion of the heart. We already talked about the T wave, so I'm not going to spend any more time on it. We said a U wave was representative of what? Come on, somebody help me out.
Abnormalities.
Electrolyte imbalance. So a U wave indicates hypokalemia. So that means a low potassium. Could electrolyte disturbances kill you? Mucho. El dedo. Broski. Interchangeable. You can. I would. Like arrhythmia, dysrhythmia, they mean similar enough to where if I'm saying, hey, he's got some kind of dysrhythmia, you'd know it's funky. That speak to anybody? You know, of course you don't. So any deviation from the heart's electrical rhythm, any deviation from the heart's normal electrical rhythm is an arrhythmia. So it could also mean the absence of electrical activity. Causes of arrhythmias is myocardial ischemia, necrosis, dead tissue, infarction, dying in dead tissue, autonomic nervous system imbalance. What you got? Palpitation is just a uncomfortable awareness of your own heartbeat.
So it's actually not like
For some people, it could be the presence of some type of arrhythmia occurring, But for some people, it could also just be a stress response and a psychological awareness where they're like, if there's a room in Switzerland that can put you in, it's supposed to be the quietest room in the world or whatever. And being in there will drive you insane because you can hear your own heartbeat and other body functions, and it makes people go mad. Totes. Apparently, it's pretty terrible. It's like a torture thing. And again, but for most people, palpitations happen all day, every day, and every one of us will throw a PVC or two throughout the day. Like if we go and run some stair steppers, like I'm gonna throw a few. You might throw a few. Yeah. No, it's an arrhythmia. It is, but it's like a normal deviation based on the stress we put our body under, and we cause our ventricular tissue to become slightly hypoxic.
So that's kind of like a back door for the school.
Yes, a little bit. A little bit. I don't care. I'm not your doctor. You're probably dying. I'm WebMD. It's cancer. You got foot cancer.
So we know that it's underlying caffeine. Feel a lot.
So when we said autonomic nervous system imbalance, yeah, you drink a bunch of caffeine, you cause that son of a gun to fire off far too fast, far too much, far too often. You throw off the rhythm. Rhythm is a dancer. You throw off the rhythm, there's not synchronicity that'll occur, right? That means it's not going to be firing and filling and unloading the blood at the exact same time in a rhythm, in a pattern. So yes, but it's normal for most of us to throw a PVC from time to time based on the stress we put our body under. Yes, but for the most part, arrhythmias can occur. They don't have to always be deadly. They can be transient things that our body goes into and then comes right back out of. But for some people, their bodies get stuck in an arrhythmia state, and it can become deadly to them. So again, myocardial ischemia, necrosis, infarction, autonomic nervous system imbalance, which again can come from what? Alcohol, drug use, monsters. Celsius would never do that to you, though.
Why not?
Because I said so. And they're delicious. I do not have a problem. I can quit anytime I want. Is this an intervention? So causes of arrhythmias: blood gas abnormalities, including hypoxia, abnormal pH. Why an abnormal pH? Well, if you're really, really acidic, you'll start to throw some metabolic disturbances around, and your heart will not like it. Electrolyte imbalances: calcium, potassium, magnesium, trauma to the myocardium, drug effects. Hell yeah. Electrocution, usually. Other arrhythmias: how about hypothermia creating a J wave or an Osborne wave? CNS damage. What are idiopathic events? No doctor, no medical science can explain it. Idiopathic means we don't know. Have you had your heart looked at? Said you threw? No, well, it's idiopathic till you don't get it looked at. So you're saying you have palpitations that take your breath away, and then you don't want to go to the doctor. Okay. Brilliant. You've paid your tuition, right? Then you have my permission to die. Interesting. So it could be normal occurrences. Why would it be a normal occurrence to throw an arrhythmia? Well, they might have been born with it. For a young woman born with like extranodal pathway, she might go into SVT from time to time. It can happen. Now, what are some other causes of cardiac dysrhythmias? Bam. Tell me about it. Whole bunch. Rheumatic heart disease, cor pulmonale, generalized hypoxemia of any cause, increased vagal tone. We call that the commode code. Pushing too hard. You know, I told you to drink your prune juice. You can listen to me. You're in a straining now. I hear you. You know, with that dome power bar squat. Taco Bell would never do this to you. You want to clean your colon? There it is. So increased sympathetic output, drug toxicity, poisoning, hypothermia, metabolic, and then of course trauma. There's a lot of reasons and causes for us to have arrhythmias. And again, it could be a normal occurrence for that patient. This is why you should always get a history if you can and find out. You know, honestly, if I'm being honest, most of the people I've had to cardiovert, they knew I was going to have to cardiovert them. They said it. Hey, the medicine they give me don't work. They usually just electrocute me. Hell yeah. I got you. I've been looking forward to this all day. I'm just waiting to grab somebody and do it. Trying to see what that'd be like. There you go. So a lot of time, and not every time, but most of the time when I had to do that, they knew it was coming. They've had it before. It's not it's an abnormality. It's an arrhythmia, but they had been through it enough where they knew it was a normal occurrence for them, and they knew the right treatment for that was synchronization and cardioversion.
That's something we have to do. Maybe you just shock them a few times to get their heart back in the rhythm, or is it something you have to do for the length of time?
It really depends on your patient. Most of the time, if you hit a patient with some of that electrical get right, the heart will be like, all right, I'm cool. Okay. But there are some patients that get caught in what we call a reentrant tachycardia, where the electrical conduction gets caught in a loop, and it's hard to break out of that loop. They might need the administration of medications to suppress that ectopic foci, in addition to electrophysiology to convert them. It's not always enough to convert them out of the rhythm. It's that you have to suppress what was causing it and stop it. Yes. You've cut the head off the weed, but you didn't pull it up by the root. Basically. Everybody understand that analogy? Who gardens? Who don't?
So we all right, so once you stop that rhythm, does the body automatically try to get them from a regular rhythm?
You would hope that control alt delete that you gave them would automatically throw them back to the right rhythm where the SA node would take back control. However, we can't rely on that. You would hope that would happen because the body has compensatory mechanisms where it would try to do that. But just like if you control alt delete your computer, don't it sometimes freeze? Don't it sometimes get stuck? The heart's the same way. What caused the arrhythmia in the first place? And if it's not something we can actively deal with, like an sick sinus syndrome or some kind of nodal disease, or a cardiomyopathy, which is a disease structure or process that interferes with the heart's normal functioning, we could be looking at it repeating itself. So we might have to continue with the harsh, invasive treatment. I didn't run the call. I've never had one like this, but I've had several friends of mine that ran patients that had required multiple doses of electrophysiology or cardioversion. Their heart just kept going right back to whatever was causing it. So in most cases, no, but let's not say never. Everybody feeling good? Love it. More terms to learn. We've talked about ectopic foci, and they are enhanced automaticity, automatically depolarizing, producing ectopic abnormal beats. Abnormal beats. Then we have reentrant. These are isolated premature events that are usually tachycardic in nature that alters two branches of conduction pathway, slowing conduction in one branch and causing a unidirectional block in another. What does that mean? It isolates the electrical conduction in one area. And then think of it like a ping pong ball. Goes back and forth until it gets faster and faster. And it doesn't break out of that loop. Does that make sense? I have pictures coming. I know you like pictures. They don't pop up though. That okay? And then morphology is just a fancy way for saying the appearance of the waves, the EKG waves. The morphology means how's it looking? Is it big, fat, juicy? Is it not? I'll give you a second to make your notes and we'll keep on keeping on. Life's a garden, man. You got to dig it. You're not first, you're last.
First, you're lying.
Well, I was high when I said that. Based my whole life on that. I love crepes. All right, everybody good? Ready to roll? Based on the amount of material I'm giving you today, I'm going to slow the process down. I don't think it's a good idea for me to finish cardiology 2 today in its in all completion, because I think that I would lose you, and I'd rather slow down cardiology and not lose you. So we'll see what we can do. Let's just see what we got. Ooh, much more. It ain't that much. We can do it. I believe in me. Not y'all, but me. All right, premature complexes. Gabe, tell us about coming to the party premature. Means you arrive earlier than expected and disappoint everyone, right? So a complex that arrives ahead of schedule. This can arise from sinus node tissue, AV nodal tissue, AV atrial tissue, or ventricular tissue. So let's take a look at the pattern here. We have what going on? Better if I do it here. We have a regular, irregular. So it arrived early. What could cause it to arrive early? What was the term ectopic foci? What did it mean? Okay.
Enhanced automaticity, automatically depolarized, producing a number of beats.
Okay. So some pissed off cell had enhanced automaticity. He's like, look at me. I'm the captain now. He tries to take over the show. So how does this occur in an event, in a pattern, a sequence that makes it recognizable? How is it regularly irregular? Well, I'll give you an example. Chapow. I told you about bigeminy, did I not?
Mm-hmm.
All right, so taking a look at this. We have normal P wave, spiky P wave, normal P wave, spiky P wave. So I have a different looking P wave and an early complex arrive every other beat. So what you're looking at is a PAC, premature atrial complex. A premature atrial complex. So how does that affect this right here? That means there's atrial tissue that is coming from an impulse generation site that is not the SA node. Early. Why is it bigeminy? What does bi mean? 2. So every other beat. This one's called trigeminy. What does that mean? Every third beat. The bottom one's called quadgeminy. What does that mean? Every fourth beat. So normal, spiky, early, normal, spiky, early. Why do you think you need to count the R waves and make sure they're the right length apart? Stuff like that. So a premature atrial complex can tell you what? That there's something in the atria pissed off that's got enhanced automaticity. It's trying to depolarize and take over the heart's rhythm and rate. The heart's rhythm and rate. What about escape complexes? These are what will occur later than expected. So like O'Neill always comes here later than expected. Walters always later than expected. Who else? Lots of students from past years have arrived later than expected. So what does it mean? It means that it gets caught up in a unexpected cadence where the rhythm generation comes later and it throws off the rhythm's regularity. like you showed me in the book earlier. It is possible there's a delay in conduction. The sinus node might have had a sinus pause where it's like, I'm lazy, I don't feel like generating an impulse right now. So it misses and drops a beat. Make sense? Let's talk about ectopic foci and morphology. So if you look on the screen, you can see that a sinus rhythm will produce a waveform that looks like that. Perfect upright P, spiky QRS, lovely little T wave. Then right below it, we have a junctional complex that would create what? There's no P wave. Where are you? Well, look at where the impulse is coming from. It's coming from right here at the junction. So if the impulse is generated here and travels down, it's not going to have a P wave. It'll either have an inverted P wave or it won't have one. Well, think about the right ventricular foci over here, this guy. He's big, wide, and juicy, ain't he? And look at the left ventricular foci over here. That's some kind of fascicular block going on. See the aberrancy? We'll talk about that more later. And then the ectopic foci here. He is coming from the junction as well. What does he have? An inverted P wave. Everybody follow me? Ish, loosely. If we're looking at V1 and it's bifurcated, that's just, here's what happened. The electricity was driving and see it got stopped right there. And find another way around. So a right bundle branch block does have the bunny ears or the bifurcation. You're right. But for this guy, we can see it was trying to travel through a piece of tissue and it stopped. The morphology of the P wave. Tell me about it. Oh, yeah. So we talked about vectors again. What was that? So a vector would mean what? This fella right here, righty thing, is traveling towards a positive electrode, right? So therefore the P wave would be upright because it's flowing the normal path. Now what happens if I have a patient that's got axis deviation, which we'll cover later, and the electrical impulse is traveling towards a negative electrode? I'm gonna have a negative deflection here because the electricity is traveling back this way. Again, that could happen because of a junctional rhythm. There is your junction. Right there. So what is that going to cause? It's starting the impulse from here versus up here in the SA node. So therefore it must travel where? From here down. And if there is to be a depolarization of the atria, it must travel where? Back this way, doing retrograde depolarization. I was inverted. Nobody? Damn all of you.
It's one more section.
Does it now?
Do we treat that?
Are they symptomatic? So a junctional rhythm, you have junctional escape, junctional accelerated junctional, junctional escape, accelerated junctional, and junctional attack. Again, this is all based on speed. So a junctional escape rhythm runs about what, 40 to 60, accelerated junctional runs 60 to 100, and then junctional attack runs 100 miles an hour and over. If they're okay, nah. If not, yeah, they're too slow and it's causing them cardiac compromise, speed them up, give them some atropine, or talk about pacing them. Or if they're in junctional attack and they're faster than 9 hells, I got something for that. I can try adenosine, but adenosine does what for me? It'll cut off the synapse at the AV node. Is that going to stop him? Nah, he'll probably need something more spicy. Oops.
How the junctional rhythms were, they were originated at the AV, so why wouldn't?
The AV junction. So right there below it. See the cutoff there right below the node? The junction there where the AV node meets the tissue and the intranodal pathways below it. That makes sense?
So the junctional rhythms don't just start at the AV themselves, they just start at
Below it. Yes, sir. I've rarely seen junctional rhythms. And normally these patients were sick as crap. What would cause the loss and destruction of the SA node and AV node to where the AV junction down there has to take over, it would be something along the lines of some dead and dying myocardial tissue. The conduction system was not being fed, so the SA node died. I mean, we have a line of succession. The king is the SA node. If he goes out, AV node tries to take over. If we're at the junction, there's been some serious heart compromise take place. You feel me? So if we do have a junctional complex, it will either be inverted or it might be buried in the P wave. Excuse me, QRS, you're right. I like it. Now, ventricular morphology. Oh, they all look what? Big, wide, and juicy. How do I know it's coming from the ventricles? It's big, wide, and juicy. What also do you not see? There ain't no P wave. Why? Because the bottom of the heart is the one originating the impulse. The bottom of the heart is the one originating the impulse. How do I know? It's big, wide, and juicy. Mm-hmm.
So one on the ball is inverted, or is it just that smaller spike?
Oh, yes, it's just that QRS complex. Usually you'll have no P's, and it's going to travel in the direction away from the impulse generation. So this guy, the red star, he would generate an impulse over there in the right ventricle, and it looks like he's trying to send the signal back upstairs. That makes sense? Because he's inverted. If it's inverted, he's trying to send it back upstairs to the negative electrode. Who's big, wide, and juicy? Ventricular complexes. Anything over 3 blocks wide is ventricular. It ain't gotta be tack. It can be idioventricular where it's slower in Christmas. Honestly, a lot of times when I see a cardiac arrest come back, sometimes they're in a big, wide reperfusion style rhythm where it's like a kind of an idioventricular or something slow and big and wide. It's not always like a popping back into a normal sinus. Matter of fact, that's been very rare for me to see. So if it's big, wide, and juicy, high, where's it coming from? All right. All right. Aberrancy. We spoke about the morphology or the appearance of a wave when an impulse hits an area of obstruction. So imagine me and Thornton are playing basketball. She throws a ball up. What's going to happen? No. Hack that thing. No. Not in my house. I'm going to dunk on it. How would you like that? You wouldn't like it, would you? Very, very fun for me, though. So what happened is the electrical impulse traveled to a spot. And then what happened? It hit an area of obstruction. There is a right bundle branch block. What is that little thing that's traveling over there? Let's see. There's a block here. And this is the right bundle branch. This is the left bundle branch. There's a bundle branch block. So as the signal traveled to the ventricles, it hit the area of obstruction right here. Then it did what? Found another way around. That is called aberrancy.
So was the block caused by an area of tissue?
Yes.
Is that the only thing that can cause it?
Not the only, but the most common. Could be a sign of previous MI, could be a sign of drug abuse, could be a sign of some type of metabolic dysfunction going on. It could be a sign of a possible, cardiac structure that's growing abnormally there. There's lots of different reasons. Most of the time, though, it's due to dead tissue. Because can dead meat beat? Can electricity travel through it? No.
So when say somebody's had an MI, they'll have this type of rhythm for the rest of their life?
They should have some type of issue with that, yes. Fusion Goku. The merging or melding of two or more waves at the same or nearly the same time. It can be isolated or actual fusion. Isolated or actual fusion. So what does that mean? It means it's either a one-time deal or it could be like, this is the new normal. Let's see.
You could have somebody who's had an inline and has a bundle branch block, but they could also be in a fib branch.
Absolutely. So isolated, all right, had a question?
Would, right bundle branch block and left bundle branch block look the same blade?
No, there's definite ways to tell them apart. I'll let Jason Grady get into that. He's got a turn signal method that's pretty much unbeaten. It has to do with the morphology of it and also vectors. So based on the vector and morphology, if it's sitting up or right, or if it's pointing down, basically if it's, turning right, you click your blinker up and it goes right. You're going right. If you're going to turn left, click your blinker down. It's a left bundle branch. So evaluating V1, you can use those turn signal things as it's at right or left bundle branch. It's stupid simple. He makes things super simple. That's why I'm excited to have him come visit us. So isolated fusion. We've got normal sinus T wave, but this complex right here was a premature beat, right? So what happened? The T and the P became Gogeta. One time and one time only. It was just isolated. But when there's actual fusion, two whole rhythms have actually just done what? They've merged. They have stuck together like butt cheeks. They have now fused. This is what I was talking about earlier, when there's going to be some rhythms where if there's a lot of fusion going on, I can see that this has some aspects of like I don't know, bundle branch block or something like that, but it's also got characteristics of this, and this. Could be several things going on. The heart in relation to its leads. I think I pretty much got that. What was the limb leads again? All right. What are the precordial leads? Another name for precordial leads? Unipolar, V1 through V6. I like it much. The rest of these slides are all about axis deviation. I'm going to play you a video to make it stupid easy. Then I've got these cheat sheets. Cheat sheets. I like cheat sheets. So let's play the video.